Okay, well, welcome everybody to our second learning session for the NSDPQC. I am going to hurry and get my presentation up. So we are so excited that you all have joined us today. I'm gonna go through our agenda really quick. We've got a video we'll watch, and then it's just a list of our speakers. We do need to excuse the All True Blood Pressure at Home program. They were flying home and got stuck in Minneapolis, and they're going to be on a flight coming back to Grand Forks during this meeting. So we will excuse them. We'll bring them back for our next learning session. But this is kind of going to be the flow of our meeting today. And then let's jump into this video. So this video is from the CDC's Hear Her campaign. And this is Allison Felix's story. If you don't know her, she has been just this powerhouse in American track and field, Olympics, like world championships for the last like decade or so. She has 9 Olympic medals, 18 world champion medals for sprinting. And this is her story and her experience with hypertension when she was pregnant. So get all right, and let me know if you can't hear it. I will fix that.
I can't hear it yet.
Oh, dang it. Okay, I went in before and I clicked the share sound button and thought I was so prepared. I'm sorry. Here, we will try this again. Back it up.
I was so married to my birth plan. You know, I imagined what it would be like, and I studied and I read and I went to classes, and I felt really prepared to have this natural birth. But what I did not prepare for was a scenario where everything goes south. Hi, I'm Allison Felix. I'm an Olympic athlete and a mom, and this is my story. Being my first pregnancy, I was feeling really great. You know, I trained throughout my pregnancy. I was running every day. I was in the pool. I was lifting weights. I felt really strong. So it was my scheduled routine appointment. I was sitting back in one of the rooms waiting for the doctor to come in to see me. And when she did, she mentioned that she wanted to hook me up to be monitored. I started to think, I wonder if this is normal, and I wonder what's going on. And finally she came back and she said that she had some concerns and she wanted to send me to the hospital for further testing. That's when my heart kind of sank and I was like, wow, this must be something, you know. I kind of heard of the statistics of Black women being more at risk for complications, but being a professional athlete, I never imagined myself in this situation. At 32 weeks, I was diagnosed with severe preeclampsia. My husband was coming from work and he met me there and we were sitting together and the doctor came in and she just said that things were still concerning and that they wanted to admit me to the hospital. That's really the point where things got scary. Doctors and nurses were coming in and they were concerned, and I remember at one point the doctor rushing in and saying that, we cannot wait any longer. We're gonna have to rush you in for an emergency C-section. I am scared, I'm terrified, but I'm not really concerned about myself. I'm just worried about this little tiny baby who is not ready to enter this world yet. All I was thinking is just, I want a healthy baby. I didn't imagine, not even being able to be in the same room as my daughter and not being able to hold her until even the next day. And Cameron was in the NICU for a month after she was born. I stayed in the hospital for a while and I had some complications that come along with preeclampsia. It was just a really scary, tough situation, but I feel so blessed that I came out on the other side of it. There are so many women who do not walk out of the hospital. They are not there to raise their children. I really want women just to be aware, to know if they're at risk, to have a plan in place, to not be intimidated in doctors' offices, and to be heard, to be persistent about anything that does not feel normal, because I know how important it is. I know how scared I was, and I know how I didn't feel prepared or educated, and I don't want anyone else to feel that way.
Sorry.
Hear her.
Oh. Sorry, the next video started playing and I started hearing it. So I really love her story because it's just a good reminder that, even our healthiest of patients can still be at risk for hypertension, and something we need to, look for in each patient. Our goal today is to collaborate. We are collaborative. We want, everybody on their cameras. We want discussion, and so don't be afraid to come off your mic. We'll jump into our presentations right now. Our first presenter is Tiffany Knopf. So everybody probably already knows her. I'm really sorry. Okay. Okay, so she is the Health Systems and Hypertension Coordinator for the North Dakota Department of Health. Many of us already know her. She presented at our last one, and she is our contact for all of the hypertension training. So I will turn it over to Tiffany. Do you want me to share the presentation on my end, Tiffany?
You can, that's fine.
Okay, look at that.
Good morning, everyone. Are y'all staying warm? Holy cow. I have a friend in North Texas and she's like complaining about their cold snap, and I sent her a screenshot of the weather. I'm like, no. She's like, yeah, I'm pretty sure everything would freeze here. I'm like, yeah, so Texas shuts down when it's like 0. So they would be like at a standstill. So
my sister's in Texas and just sent a picture. She has a sheet of ice over like their whole road.
Yeah, I used to live in New Mexico, and they literally had a tractor, and that's what they plowed the city with because they never got snow. So yes, I can absolutely empathize with that. So, well, good morning, everyone. I am Tiffany Knopf. I am the Health Systems and Hypertension Coordinator for the North Dakota Department of Health. A lot of this presentation, for those of you that have been with us all the way through the original pilot, is going to be just a tad of review, but we do have some discussion points that I want to make sure that we hit on this morning. So Morgan, you can go ahead and go to the next slide. So just a quick review. One of the things that I help coordinate for this project is the blood pressure protocol training. For those of you that haven't attended or this is new information, we developed this training with Blue Cross Blue Shield back in 2016 as part of a Million Hearts collaborative. We so far have trained 2,400 health professionals, everything from dentists to chiropractors, all the way up to MDs, and CEOs of health systems that want to learn more about blood pressure protocol and what they can do. Our evaluations from all of the attendees do indicate that 92% of them were taking blood pressure incorrectly. That's a self-report, and that they are committed to making a change to how they take blood pressure. And then we, thank goodness, had some foresight and were able to convert this training to a recorded training in 2020. Go ahead, Morgan, you can go to the next slide. So I'm getting a little feedback from Nicole. Could you put her on mute, Morgan? Thanks, dear. Okay, so a couple of the objectives from the training is obviously we talk about the prevalence of hypertension in North Dakota, and we have actually gotten data recently for the last round of trainings from South Dakota as well. So for the South Dakota sites, we do present prevalence data of hypertension in North Dakota and South Dakota. We talk about why accuracy and measurement is so important, some lifestyle modification options that medical staff can talk with their patients about. We do provide a couple of tools as well as workflows and demonstrate proper blood pressure cuff sizing as well as proper technique. And then we do talk about alternative sites. So we talk about wrist cuffs. There are finger cuffs on the market. We talk about taking blood pressure on the thigh and the forearm. So we do truly talk about all the different options for taking a blood pressure. Okay, Morgan, next slide. I know you got a lot of things going on over there. Being the admin of a meeting is a lot of work, I know. So a couple of the competencies that we really try to drive home. And the reason I like to review these every single time we talk about blood pressure protocol is because these are all of the common mistakes. Having a patient seated with their back supported, legs not crossed. We all do it. We sit down, we instantly cross our legs. So having their feet uncrossed and flat on the floor, a bare arm. We just talked about how freezing cold it is in North Dakota. We all are wearing a million layers. We really need to be taking a patient's blood pressure on their bare arm and not having that cuff over clothing. If they pull up their sleeve and it's too tight around the shoulder, that's creating a tourniquet. Also, we're creating inaccurate blood pressure. Not having a nurse or a patient talking during the blood pressure is probably one of our most common errors right after cuff sizing. So really, I know, and we're going to talk about this in a minute, nurses and medical staff are really pressed for time, but not taking a patient's medical history or chit-chatting about COVID or whatever it may be while they're taking blood pressure is really, really important. Having the patient sit, especially in OB, they're probably running from an ultrasound or running from a lab and running up to their appointment. So allowing them to sit for a few minutes before you're taking that blood pressure. You can talk to them during that time, but just, not having them sit down and slap the cuff on right away. And then if a patient's blood pressure is elevated, talk through all of the different reasons that it could be. Did they just have caffeine? Were they smoking? Hopefully if they're pregnant, they're not. But if they were recently pregnant, were they smoking? For pregnant women, especially a huge consideration is, do they have a full bladder? If they just came from ultrasound, and if it was like me, I remember when I was pregnant, I would drink a gallon of water before I went into my appointment because I did not want to have an empty bladder and then not be able to do what they needed to do at ultrasound. But then honestly, like I was peeing every 20 minutes. So, if they have a full bladder, that can raise their blood pressure up to 15 millimeters of mercury. So making sure that, that we, talk to the patient if they have a full bladder, allow them to rest, and then make sure that it's retaken. All right, Morgan, you can go ahead to the next slide. So we so far, as part of the May training, as well as the December training, have trained 320 medical staff across 11 locations. And the most important thing is, are they going to change how they take a blood pressure? And 82% of your attendees from the NSDPQC did indicate that they were taking it incorrectly and that they were going to make a change. And then here's the things that they specifically listed in the comments. Cuff size is the top issue that they stated that they were going to do better. Patient positioning, so making sure patients are seated, arm at the level of the heart, and feet not crossed and flat on the floor. Not talking to the patient. We talked about this while they're taking the blood pressure. Cuff over clothing. And then again, another important consideration with OB is ensuring that the patient has an empty bladder. All right, you can go to the next slide. So here's where we got to have a little bit of a conversation. And this was, really at the request of the leadership committee for NSDPQC, was really just wanting to hear from you all about, these are the top barriers that your staff across the 11 sites indicated as to, they're admitting that they are not taking blood pressure correctly. But these are the reasons that they may not still be able to take blood pressure correctly. So they indicated that time constraints would be a factor in if they could take blood pressure correctly or not. Resource availability. So this includes the correct equipment to take it correctly, and then workflow. So I just wanted to hear from you all. Let's start with time constraints. Under time constraints, what are some time constraints that you see within your practices that could cause a staff to feel like it can't take the time to take a blood pressure correctly? Can you guys think of anything that would cause that feeling?
Feel free to come off mute or put it in the chat if you're more comfortable with that.
I'll start. So just some of our providers' clinics are just way too busy, and we're running 2 or 3 rooms at a time, and the nurses are, you only have 1 nurse. So really just simply staffing, which is worsened right now with COVID for sure.
Absolutely. And that came up, people mentioned that in the resource availability too, is just having enough staff to feel like they could take it accurately and get back in for rechecks and all of that. But yeah, you're right, Colette. I mean, I totally know you guys are running from room to room to room, and that's going to be a huge challenge. No, it's not as big of a barrier. I see in the comments, it's not as big of a barrier in the hospital with time, but to be honest, it really probably depends on the day, right? If there are lots of women that are birthing and low staff, and women who are just being monitored or in a room where they're not in active labor, probably are a lower priority, right? So they may truly run in, slap on a cuff, get the BP quick and run out if they're working on a lot of other things, right?
Sure. Yeah.
Yeah, but you're right. Other time constraints that could come up for staff.
I'll add one more, Tiffany. So, and I know that we've brought this up to you before, but the time for the nurses to watch this education piece, that's been the biggest barrier in our facility. And I know that there's some limitations on it from your guys' end, but again, our nurses have been just asking, like, is there any way it could be watched at like their own time availability, even if CUs aren't given in that scenario? But that's, time wise, like that's been the biggest challenge to getting all of our staff to do this.
Absolutely.
Yeah, that's been a problem in Brookings too.
I think another time one I would see is, when we have larger patients, we might not have, large cuffs in every part of the clinic. And so they might not have time to go find the right size cuff. And so then they just kind of use what's available.
Absolutely. And that came up under resource availability too. So, when it comes to all the challenges that you guys have brought up so far, there are opportunities to tell staff or help staff prioritize what is most important, right? So if you have a woman coming in and you know that there's all of these things that have to be done, weight, blood pressure, all the other checks. It's been a while since I've had a pregnant mama visit, but all the things that need to be checked, where is the priority for time? So, if they can slow down, so if they slow down and they follow the process, we've actually done studies. We've had nurses go in, do all the things, we time them on a stopwatch. So we had 5 nurses go in and do their standard process as they do. So we timed them from when they went into the room, did all their intake, and then finished the blood pressure the way that they traditionally take it, versus we had them go into a room, do their standard intake. It only added 45 seconds to stop and take the blood pressure correctly. Now, I know you're going to say 45 seconds times 100 or some patients a day. It does add some time. It's going to add time, but at the cost of potentially taking blood pressure inaccurately. The other thing I'm going to say about that is they found that when they were taking it accurately, they had to retake it less times because the blood pressures were in the correct range, right? Because they're slowing down, they're not getting falsely elevated blood pressures. So they didn't have to go back and retake them and end up finding blood pressures that, were now within normal range once they followed the standard protocol. So just something to sit and chat with your staff about to make sure that they know that, yes, you may feel like you're saving time by not following the proper process, but you actually are probably adding time because you're having to go back and recheck by getting an inaccurate reading. But on top of that, you're also, you guys know, if you have a scale that weighs incorrectly, what's the point of taking a weight, right? So what's the point of taking a blood pressure if you know that the numbers aren't accurate because they're not following the proper process? Okay. Simple thing as talking to a patient can increase the blood pressure up to 10 millimeters of mercury on the systolic side. That's huge when it comes to a patient that may be borderline. Okay. And then workflow. Is there any challenges with workflow that you can indicate within your facilities that would cause them to take blood pressures incorrectly or not allow them to take them correctly?
Well, I think in the hospital, the big barrier we have, they come in and they sit, we don't have a chair we put them in. So my question is, how do you take it properly when they're in the bed? And then also when they're in labor, epidural, you know, they're going to be on their side. So just wondering, you know, we address sitting in the chair, sitting up straight, but like more information on in the hospital.
Absolutely. And really the most important thing is just being able to account for that, right? So in the hospital, you're going to have different standards. You know, 120/80 is not going to be your standard average blood pressure for a patient with their feet elevated. So feet elevated will tend for most patients to raise it 10 to 15 millimeters of mercury on the systolic and 5 to 10 millimeters of mercury on the diastolic. Okay. So it's not a perfect science because every patient is different. You add an epidural, you add medication, you add the stress of labor, it's a whole different situation. But when you get to the hypertension crisis side of things, it ultimately is all out the window. It doesn't matter how the patient is positioned. If you're doing the best you can to not talk to them, you know, don't try to remove all the barriers you can. Having their bare arm, having a correct cuff size, not talking to them while the blood pressure is taken, giving them a couple minutes to breathe. Again, active labor, that's again out the window, but controlling the factors that you can is the most important. Not having the husband talk. My blood pressure when my husband was talking when I was in labor was higher than when he wasn't. I was in my position, so in my current role when I was in labor with my son, and so we were testing some things out. And thank goodness Dr. Lay's at All True, she was my OB at the time, but she was willing to do some things, to try some things out for me. And sure enough, my husband talking to her annoyed me enough while I was in labor that it raised my blood pressure. So just really having everybody in the room quiet, not having other nurses coming in and out talking, not having the students that were watching my labor is my second baby. I was like, whoever wants to come in is welcome, but not having them chit chat while the blood pressure is being taken. All of those factors truly influence a patient's blood pressure. Something on the TV, you know, just having the room be quiet during that process and giving the woman just a minute to compose herself before slapping on the cuff and taking that blood pressure, especially if you're coming in with some maybe not great news or whatever it may be. Just trying to control the factors that you can.
Those are great tips.
And I'll say, I always harp, my nurses will laugh, but I always harp on the auto cycle, like making sure your nurses aren't setting it to auto cycle and leaving the room, because I can't tell you how many times I'll walk in a room and then the patient's breathing through a contraction and the cuff starts going off. And then I'm trying to turn it off and unplug it. And then I'm just messing things up, but just not doing auto cycle too.
Yeah, watching your patients while the blood pressure is being taken. You know, we all have our phones now. We don't even need to physically hold them. I'm still an Android user, so I still physically have to hold my phone. But all of you with iPhones, you have your iWatch. You can see a phone call. You can see a text message. You can see Facebook on your wrist. And if they're taking a blood pressure and they're lifting up, reading something on their phone, and you have your back, or on their watch, and you have your back to them, you don't know that now they've moved and changed their position during that blood pressure. So just being engaged if you do have automated cuffs and watching the patient throughout the process. Also, if the cuff becomes too tight when the automated cuff is on there, that's clearly going to raise their blood pressure and could cause some trauma to the arm. And talking about cuff size and having the availability of a large cuff, it's really important. We found in several settings across North Dakota that has worked is we try to have the staff spend a few minutes in the morning reviewing the patients for the day and being prepared with the patients that could/would need a larger cuff. If you're documenting cuff size from the previous visit, you would be able to know that they would need a larger cuff. We've had a couple facilities that have used med assistants, and those med assistants are responsible for right outside the door dropping a large cuff in when that woman enters the room, knowing that she's going to need a large cuff, so that the nurse, when they come in, can grab the cuff and just easily walk in and not make it a big deal. You know, the PTSD, the trauma that we could cause patients by going, ugh, the standard regular cuff doesn't fit. I really need to go get the large cuff. Hold on one second, right? None of us like to hear that, that we don't fit in a standard size, whatever. And so, you know, just making sure that you try to find a process or a workflow that could assist them in having that large cuff available, or having more large cuffs available. About 40% of our patient population across men and women need a large cuff. So with 40%, and then I'm sure that's even higher with OB, just because, you know, women are gaining weight that they're not used to carrying. I gained it in my arms. I didn't need a large cuff, but I gained it in my arms. And so, you know, that can sometimes cause women, swelling can cause women to need a larger cuff, maybe more often than the standard population. But the standard population, it's about 40% in the US need a large cuff.
I think one of our workflow problems is some of our rooms are so small that there's one chair and the exam table. And so the partner sits on the chair and the patient automatically sits on the exam table. And then the blood pressure is taken with the patient on the exam table.
Yep. Kick that significant other, boyfriend, girlfriend, fiance, wife, husband, whatever it may be, out of the chair and have them sit in the chair. I know in peds, for example, you know, the patient should be sitting next to the nurse. So your little kiddo should be sitting next to the nurse so they can take a blood pressure, and they just tell mom and dad to scoot over. I've accidentally sat in the first chair right next to the nurse because my kiddos were little, and they say, you know, actually, we need to take a blood pressure. Can you have your kiddo sit in the first chair? Or, hey, Sheffield, come sit right here in this first chair, and then they kick me out. So, I mean, I think, you know, the patient is the most important, and getting an accurate BP is important. Hubby can go stand in the corner until the wife, you know, is ready to have the rest of her visit, and then she can go sit on the table. Inconvenience those significant others.
I guess going to cuff size, sorry, I'm post 24, but going to cuff size, we have a patient right now who's requiring like a thigh cuff on her arm, and it literally says thigh cuff on the cuff. So not only is that stressful enough, but then the thigh cuff is too wide for her, you know, like the distance from her shoulder to her elbow. And so then it's like this big deal of like, well, the cuff is technically too big in that sense. Right. And so, and this has been, she's one of our long-term aunties. And so it's been this like thing of like, well, the cuff's not really accurate because it's too wide, but also the other ones are too short.
Have you tried forearm?
Yes. And it's still a little on the wider side for her forearm. Okay. Like, you know,
I didn't know if a large cuff on the forearm would work. Some individuals that are carrying weight in their arms can have like a conal shaped upper arm. And so
she sure does. Yep.
Yep. So you won't get an accurate reading that way either, because it's not fitting correctly, regardless of the, you know, the height, you're still getting a conal shaped arm. And so in that case, a lot of times we will go to the forearm and do the best we can. Now, again, further you move away from the heart, it is going to be more elevated. But again, you know, if you feel like you're not getting a good reading regardless, maybe try the forearm next time and see if that is a better fit with, you know, the large cuff. Otherwise, you know, truly measuring her arm the next time she's in and seeing if there are other cuff options out there. There are several companies who now make like an extra large blood pressure cuff. They're harder to find. They're more specific with equipment, but it might not be a bad thing to have one on hand if that's something that your facility is willing or able to locate through their supply chains. But, you know, really measuring the patient's arm and seeing if there are any cuffs on the market that would work for her. Just some advice, but otherwise the forearm is probably going to be your best bet. with that type of patient if a large cuff works for her forearm.
Yeah, I'll have them remeasure. We measured her like several times
I
on her
know.
admission. It's just,
Is there,
but you
if-
could idea about looking in. Oh, sorry, Dr.
Oh,
Lasaka.
no, I was just gonna say on that line, because then we had a patient like this like 2 months ago that I remember the same issue with. Is there like just a quick reference sheet for alternative ways to measure? I know like it's mentioned in the AHA guidelines, but it'd be almost just nice if there was a couple alternatives, like a reference sheet or something we could put together, and some of these scenarios, like the cone-shaped arm. The other thing we've ran into that I haven't been able to find a clear answer for is some of these cuffs are, you know, like a large cuff, but there's a large long instead of a large regular. And so how clearly does that, like, how does that affect it? And what's the optimal choice?
Yeah, so as long as the cuff fits the patient, you will get an accurate reading. So the cuffs that are created, so for example, the large long could also, like you said, be a great option for this patient because their arm isn't physically any longer. It's making the cuff longer, right? So it's a large size cuff in the height, but it's a long, so it can go around a larger patient. Those are calibrated to get accurate readings based on their cuffs, based on the cuff size. So it's not, you know, as long as it fits the patient, it is calibrated to get an accurate reading. If it doesn't fit correctly, if you have too much or you have the bladder of the cuff going over and around each other, it won't get an accurate reading, but you're not getting an accurate reading probably with the other cuffs that aren't fitting correctly either. So yes, you're right. There's a lot of different options out there. And those are all, if they're sold by a reputable place, then they're, you know, distributor, then they're going to get an accurate reading and they're calibrated for that. So just having, I mean, even across different brands, you know, you'll go to Welch Allen and it'll be a completely different length and height than, you know, some of your other brands. So it's really just, there isn't a perfect brand. They all just are really different depending on the model with what they offer. But trying to have as much of a wide variety as you can. And of course, always thanking the patient for their patience as you try to find an accurate cuff, because I'm sure, you know, it is frustrating for them, but it's also going to be frustrating if you try to start to treat them for elevated blood pressure. It's just really, truly not elevated, or the vice versa. You miss an elevated blood pressure, the blood pressure is reading incorrectly as low. And Colette, I would absolutely be willing to work with our trainers to try to develop some sort of quick handout, and then I'll run it past you guys, and then I'll make it pretty, so you guys
I
can.
think that'd be great.
Yeah, absolutely. And we can, you know, we can include it as like common considerations for elevated BP, and, you know, just thinking through, especially putting having an empty bladder on there for OB.
Tiffany, you had talked to me about having the option also of having kind of like a one-stop place where you could do, you know, the blood pressure, weight, kind of the vitals when maybe your rooms aren't set up quite right for this, and maybe you don't have as many, or you can't have, like, our clinic's pretty spread out, so you can't have all these blood pressure cuffs, you know, throughout the whole clinic. Do you want to touch on that as an option?
Yeah. Absolutely. So we've worked with a couple of facilities on developing basically a stopping point between their final room where they're going to be treated or managed or have their checkup, and having a room in between. You take one room offline or a coat closet offline, and you have space in there that the patient can have their weight checked. Trust me, as an OB patient, I hated having, no offense to Ultru, I love Ultru, but you all took my weight in the middle of the hallway. I did not want my husband to see when I crossed over that mark when I was pregnant. It was like, oh man. You know, having a space that a woman could go in, you all could do her weight, you could do her height if you needed to, take their blood pressure. You could have every cuff size that you have in the clinic could be available in that room. You take the blood pressure, could have computers in there to chart if you want, or you could have them just, you know, documented on paper and pencil. But then, you know, they do all the vitals in that room, and then you move them on to another room. So it allows you to have an option, you know, and maybe it's not every patient gets their blood pressure taken there. Maybe it's just the patients that, like you said, are going to be roomed in a room that just don't have a great layout for taking blood pressure. Then they're going to, you know, make a quick stop, have the patient stop there, get their vitals taken, and then they move on to the next room. So those are absolutely options that we've had some smaller clinics that need some renovation. Those clinics have utilized that option. We've also had that in the inpatient setting, where, you know, they're taking a woman onto the labor and delivery floor, and they want to make sure that they get accurate readings on intake. And so they stop right inside the labor and delivery floor. There's a small room. They'll have the patient sit down. They'll do the blood pressure sitting, do all that stuff, and then they'll work and move them on to the next room. So lots of different options for workflow that way. But yeah, thanks for bringing that up.
This is Katie in Sioux Falls. Remind me what we're educating staff on to have them wait sitting down ahead of that blood pressure. I think that's a great idea. I could just see people though automatically sitting in that chair and taking that BP right away.
Yeah.
And that causing some stress and anxiety. So just to remind me from the training, Tiffany, what we're...
At least 1 minute. That's all we ask. At least 1 minute of the patient seated before you take their blood pressure. And you can be talking to them during that time. That's not a big deal. Just don't talk to them while the blood pressure is being taken. So you can still do all your other intake. You could do a minute of chit chat. We all know that happens too. So, you know, just 1 minute is the least amount of time. 5 minutes is kind of the threshold, you know, that you're not going to get any additional benefits of them sitting for more than 5 minutes. But, you know, 1 minute is kind of the minimum. If you can tell the patient is really out of breath from the walk from the waiting room, or we all know the run from the car because you're late for your appointment, you know, just give them a little bit of an extra time. Because again, slapping a cuff on, if a patient is breathing really heavy and having a hard time catching her breath, you're not going to get an accurate reading. It's probably going to be elevated and you're going to have to retake it. So just giving them a couple extra minutes to take some deep breaths is not a problem. Again, I know I say that as I'm sitting from my office at home, and it's easy when I'm not in the clinic setting to advise all these things. But I think, you know, just ultimately reassuring with staff, or reassuring your staff that if you have to take an extra minute or two in the room with a patient because you want to ensure an accurate blood pressure, that they're not going to be reprimanded for that, right? That truly blood pressure accuracy is something that you value. And being reassured of that by staff they have said goes a long way. But you know, they need help prioritizing. All of us do in our lives, but having them prioritize things that are important to you and getting those things accurate is really does go a long way with your staff. Okay, any other questions on this? So I just wanted to address one quick thing with what Colette brought up about not having it available all the time, the training available all the time. So we have recorded this training, and I probably will record one of the ones that are on the screen next. If you can go to the next slide, Morgan. So these are the next 4 available dates. I have sent reminder emails to all of you, letting you know who attended previous trainings, as well as how many are registered for the current trainings. If you can get your staff to a live training, that is the best. If you can't, for some reason, if we push through and, you know, after these trainings, you're like, Tiffany, I still have a ton of people that need to be trained, reach out to me. We will not be able to offer CE after it's not live. That's just part of the North Dakota Board of Nursing. It has to be a live training for how they do CE. But I'm willing to try to work with you and give you a smaller window that I would allow them to watch it. And then they still need to fill out the evaluation, because otherwise we don't know who we've trained, how we've trained, and obviously we're paying for the training on our side with our CDC grant dollars. So I need to be accountable for that, but I'm willing to work with you all. If you're willing to try your best to get as many staff to these live trainings as possible. I'm willing to work with your site and give you a small window that they would be able to watch the recorded training, as long as you promise me that they're going to fill out the evaluations. So let's work on that. So my contact information, all of your leads for your site should have my contact information. But again, try to get them here. And the reason I say that is because they get to ask questions. The questions at the end of our trainings is honestly where we, discuss myths, right? We have staff come in and go, I've been taking blood pressures for 30 years. This is different than I was ever taught. And, we're able to kind of talk through some of those things and, and try to ease their mind that they haven't totally screwed up the last 30 years of practice, that they probably were trained that way, but process and protocol has changed. So, but that's where we talk about inpatient and having patients elevated on the table and active labor, and our trainers are able to answer some of those questions. So that's the hardest part for me of letting go of the live. Our trainers have been really, we co-own this training, so they've been really adamant that we need to try to keep it in-house. And so that it's done, only live. But again, in this case, I know you guys have staff kind of all over the place working crazy schedules. So try to get as many as you can to the live trainings over the next couple of weeks, and then message me and we can figure out a plan on a case-by-case basis with your facilities on getting this more widely available for a shorter window. Okay, can you go to the next slide for me, Morgan? All right, so again, just wrapping up here, next steps that we have for your facility. I have emailed out yesterday to all of your facilities, letting you know who has been trained and letting you know who is currently registered. So just make sure you forward that back out to staff, have them get registered. I send confirmations and then they're able to jump on live with us. And then I'll send again updated registration list next week, so you can kind of see again how many staff are registered from your facility. And next slide, Morgan. And here's my contact info. So if you need anything from me, let me know. I'll work over the next couple of weeks to get what Dr. Lazar was talking about with having, some sort of standard BP handout that talks about the alternative sites and some just standard considerations. All right, that's all I had. I appreciate your guys' time this morning. I know I probably took longer than I was allotted, but the conversation was really wonderful. So I really appreciate hearing from you all.
Yes, thank you so much, Tiffany. We're gonna hurry and just jump ahead to Alicia's presentation right now. She has to get on the road soon. I'm sorry. But quick intro to Alicia Belay. She is our current executive director for the NSDPQC, and she is the assistant director of the Health Equity Office for the North Dakota Department of Health. She focuses on maternal health, communicable diseases in her work, and her work in 2021 has been focused almost exclusively on equitable practices for immigrant communities related to COVID prevention and now vaccination. So let me stop share this, and Alicia, you can go ahead and
Hi, everybody. Can you see my screen here?
Yes.
Awesome. Okay, well, thank you, Morgan, and thank you, Tiffany, for the great discussion. I'm unfortunately, my presentation is going to be more of a presentation. There's not a lot of discussion, but just once in a while, it's good to have just a quick review of some of the concepts in QI. And so we're just going to go through a couple of things in QI to keep in mind. And I think no matter how many times I'm hearing some of these things, it really is helpful to kind of review them again. So we'll talk a little bit about QI here. So first of all, choosing an aim, and it's okay to change your aim if you already have one, and to shift it around. This is going to be your North Star. It's leading you to where you want to go. So you want to have a good aim. And we talk about aims being fast, frequently discussed, ambitious, specific, and transparent. If you asked your team today that's working on this project with us, what's your aim, they should be able to come up with that right away. And I know sometimes, with missions and things that we set up to work on in our offices, that doesn't always happen, but I'd urge you to have that aim really visible and have it be something people can bring up and talk about right away. The aim statement should have the focus, It should have a numerical goal. It should have, and that should be ambitious but achievable. So sometimes we set our goals too high and it's just really not going to be something that we could possibly ever get to, but yet we do want to have something that's pretty ambitious. And we need a time frame. You just can't have it open-ended. You need to be able to name the customer or population of focus. Who's going to get that benefit? Is it your training? Is it your birthing mom? Is it who exactly are we trying to reach here? And then define the process that you're going to be using to reach that aim, and the scope and the boundaries. And I'm going to give you an example that I think it makes it a little more real than just those points. And it's the tale of the noisy hospital. I think this actually happened, so we're using a real example, but it's getting to be sort of folklore within the PQC world, I think. There was a hospital that was hearing so many complaints. Administration was just getting so tired of people complaining about how their room is not quiet at night. And so their initial aim, well, we got to improve the percentage of patients who are reporting the room is quiet at night. This has to get better. So they talked with staff about being quiet. They dragged out their WD-40 bottles and tried to get the doors to not squeak. And lo and behold, they were still getting complaints from patients. And so they had to go back, revise. Their eventual aim has a lot of strengths that first aim did not have. They added some numbers here and they added some dates, but the really important change is they changed the scope. They broadened those boundaries. So they realized it wasn't really that the patients were thinking it was so noisy. It was they're not sleeping. And when you're not sleeping, you're laying there hearing every squeak and every noise that's happening. And so they really had to think about not just the reactive, like, oh my goodness, people are complaining about this, and instead think about really that fundamental change of what needs to happen to make things better here. So over time, they did change their aim, and they made it specific, measurable, achievable, but pretty ambitious, 30 to 60% in the course of the time period. I think that is a 6-month time period for the project. So think about your aims. You know, in their initial aim, they were working and working and working at it, but they still couldn't get those complaints down until they realized their aim needed to shift. So how do you choose an aim? You know, there's a couple of pieces of advice that other PQCs have provided for thinking about how to choose it. If you look around your facility and you think about if your niece, I don't know, they probably don't pick your daughter because that might just be too emotional. I don't know, but if it was your niece delivering in our institution, what would you want to be different here? So that could help lead to the appropriate aim. What process would need to be different to have that outcome? And then if you waved a magic wand to make outcomes better, what one or two things would look different? You know, and probably in that noisy hospital example, people aren't going to say, well, we'd really envision a very quiet hospital. No, they're envisioning patients feeling satisfied, feeling happy and refreshed when they wake up in the morning. That's truly what the outcome is, not just to stop the complaints from people. And then what is the system designed to produce for moms now? So if you think about like, well, our system is designed to make sure that everybody's, hopefully making this up, but that everybody gets out of there as fast as they can so that we have another bed available. That's probably what your system is going to be producing, is a system that is trying to pump people out fast. And if that's what you're looking for, then that's going to work. But looking at how your system is designed and what processes right now are leading you through the day, that's probably a good place to start in thinking about choosing an aim. And then choosing a change, you know, what kind of change should we choose? It should be something really innovative. You know, when we first started talking as a PQC, this was, I think, 2018, we started talking about what changes should we choose. And we came up with some really creative stuff. It was cool ideas and we thought it should be new and fresh and we're a new PQC. We quickly learned in listening in on national conversations that we should be absolutely not innovative in PQC work. This isn't a fancy research project that we're hoping to have a publication and we need something cool. We want to use the phrase steal shamelessly, share seamlessly. When you're hearing other people's ideas, what they're working on, that is very much, it's very likely that's exactly what you're going to be wanting to work on because they have some of the same problems. and they've hopefully come up with some solutions. So don't reinvent the wheel. Innovative is often not the best way to go with quality improvement. And then where can you get your ideas? I mean, you can listen today and you're going to hear ideas from other teams. You can do a quick Google search, check the research, check the literature. If you have a certain outcome that's been problematic in your facility, you can quickly do a search and find out what other facilities have done to solve it. You will find that lots of PQCs are willing to talk with you, other facilities. We can help connect you with some of them too, if you want to. We did that as a team. We spoke to many PQCs one-on-one to talk about this hypertension initiative, as well as some of the other ideas we had initially. So feel free to do that, and it gives you lots of good ideas and can tell you some of those challenges you should anticipate. The other thing is to use AIM, so Alliance for Innovation in Maternal Health, I believe, AIM, and they have bundles available. So if you pop that into Google, you'll find bundles where people have tried to solve the similar problems to what you're trying to solve. And they AIM has come up with ideas and suggestions for how you can improve those at your facility. So some of those ideas for choosing the kind of changes that you would like to have. And then focus on a fundamental change versus reacting to the problem. So let me explain what that means a little bit more. Reactive, in the world I'm living in, so often the first thing I think of, let's make a flyer. Let's put a poster on the door. Let's remind people about it. Let's do more training. Let's educate. They must not know the education around this. Let's make sure we train staff. Let's check on it more often, make sure that people are really doing what they're supposed to be doing. Some of these things are kind of our first thought all the time. And I've seen this in the field. I've been in the field a number of years in different areas, and it's kind of always the same thing, that's where our minds go. My mind still goes there. But I think the example I always think about in this area is that I've had a lot of education on what I should eat every day. I've had a lot of training. I try to keep a food journal. I'm checking on it. I'm looking up resources on the best ways to choose healthy foods. But you know what? I'm still eating not the best on a lot of days. And so that kind of more reactive way, could still go some distance. Obviously, if I don't have the education, I can't eat healthier, which is one of the things we're looking at in our hypertension initiative right now. Is people do have to know what the protocol is, the proper way to treat people. They have to have the proper blood pressure. But beyond that, all the things Tiffany was talking about on the last presentation about why is it not happening? People might know you're supposed to use the right cuff, but if you don't have the cuff, how can you possibly do it? So using these more fundamental strategies for change is likely to bring about a more sustainable change. If you see the way it's framed here, process redesign, altering approaches, changing boundaries, this stuff sounds harder, and it often is harder because how do you change the workflow, or how do you change what's actually available to take blood pressures? It is harder. But sometimes it's not. Sometimes it just takes a little bit more thinking, a little more creativity. So one of the examples that we were given that's just stuck with me for so long was getting to this idea of a fundamental change. They were talking about there was a hospital that needed to have patients' heads elevated a certain amount after a procedure. I don't have any idea what that was anymore. I don't remember, but I remember that they were struggling. They were putting up a flyer to remind staff to crank the bed up to the proper level. They had training around it. They were checking on it, making sure people were doing it, and they just could not get this to change. And ultimately, what they decided to do was creative, but it totally was a process redesign. Instead of training staff to do it properly and try to get them to do 45 degrees or whatever it was, they simply put a piece of masking tape or duct tape on the wall and said, everybody make sure that your bed is at this level before you leave the room. Problem solved. So sometimes, while fundamental changes could be more challenging, sometimes it really just takes that kind of thinking outside the box of I think it's not that they don't know how to do it, or they don't have the time in their workflow or something. They just are not able to measure where that point is on the wall. They need a visual to remind them before they leave the room to move the bed. So just thinking through those kind of changes and trying to get at more of the root of the problem sometimes versus some of our more reactive responses when something needs to change. some things to think about, to remember if the change you're proposing is going to be reactive or fundamental. If it's a fundamental change, you're going to have a long-term impact. You're going to be seeing this over time. It's not going to be just while you're checking the rooms that people have decided to implement this. It's going to be something that you can keep up for a long time, very sustainable change. And you're going to be able to know right away how it's going to make things better for patients and their families. And then when you're thinking about how do I choose a fundamental change, you really have to understand the causes in the first place. So if we go back to our example of the sleeping, the noisy hospital, the patients were complaining. So our reaction is, oh, we got to stop the complaints. Let's make sure it's quieter. But looking at the root of the problem, you kind of have to go upstream a bit, as we talk about in public health. You have to look upstream. It's not just that people are complaining because it's noisy. They're complaining because they're not getting that really good sleep that they need to feel great and refreshed in the morning. So kind of going upstream in the process if you can. And then I think talking to people who have been trained, when we give that training and finding out what the barriers might be. Again, I really appreciate Tiffany talking through some of those potential barriers, because once you got the education, you've got a staff who's motivated, that's not the end of the story. There's a lot of things that are still posing barriers. So in quality improvement, unlike sometimes research where we're just quantitative or we're taking some measurements and getting our data, we have so much opportunity during quality improvement to take a time to talk to an individual person who's trying to do this change and say, did that work? Why not? How did it go today, checking blood pressure? What happened? And some of the simple things of just asking the patient to get off the table and go onto the chair and booting out the partner that's in the room could be things that you come up with together that maybe you didn't think of before you had the conversation. So just thinking through that, because we don't want to be wasting our effort. We have such precious little time to try to make changes. We don't want to be spending a bunch of extra energy on creating flyers and manuals and training and all of this stuff, when really it could be as simple as talking to one of your staff for a minute and a half after they visit with the patient and finding that something really simple like putting tape on the wall could solve the problem. So measuring the change, just a couple of reminders about measuring the change. Oh, Dora has stopped. So when we're measuring the change, I tell you, this working from home sometimes, it is pretty wild. You can have all the TV that you want and it still doesn't seem to pan out here. So when we're talking about measuring the change, I'm going to recommend that we don't measure the cow. And what I mean by this, I don't remember why this example popped up. No idea. But we talked a lot in our PQC meetings about how when you start telling people you're going to measure it or you're going to track it or you're going to change it, they start getting really focused on, okay, measurement, and they quit forgetting, or they forget and quit thinking about the ultimate goal. Like that's one of the reasons it's super important to have that aim that's your North Star, because your aim is not, very surface level. The measurement part is not as important as the actual goal you're trying to reach. So they start measuring the cow. If you tell them we're trying to get this cow to gain weight, I have no idea. I suppose you'd want to do that before you sell a cow or something. I guess the example came from there. But you say we're trying to sell this cow and we need to get this cow's weight up. Then they start measuring it every day instead of thinking about the fundamental processes that would help that cow to actually gain the weight that it needs to gain. So we need to understand that we're measuring for improvement. And a lot of us, I was trained as a researcher and I didn't measure things for improvement. I measured them for publication. I measured them for, deep understanding of what's going on. And then a lot of us are used to getting measured. When we say there's an evaluation at work, we're going to get judged and assessed. And so really trying to shift the mindset of your team that we're really measuring only to see how to improve it. There's no judgment here. It's a learning opportunity. We're open-minded. We're just thinking about how to do this. And to me, that's been a big shift in working with a PQC, because I've had trouble with thinking about measurement and just open discussion. And it doesn't quite have the same feel as that research where we've got an endpoint or an evaluation where you've got this endpoint of judgment. And then be sure to measure enough time points. And we're going to look at an example of when you don't measure enough time points. And then be on the alert as you're measuring, whether you're seeing normal variation or improvement. So from a research standpoint, you all know there's a level of variation in many of the variables we're looking at. We don't know what that variation is. Is it a huge variation? Is it a smaller variation? So as you're looking at charts and looking at how things are changing over time, how do you know if it's really just the normal variation we would expect, or are things changing? Don't just weigh the cow, really focus on that open conversation and dialogue. So here's some examples of things that you should be always including in measurement. You should always be including an outcome. That's obvious. We wouldn't have any trouble with that. We're trying to change something that's happening usually with the patient, right? And so it directly links back to your aim. People don't forget that one. The things we do forget though are the process and the balancing measurements. So when we're talking about process, it's really, again, talking to that staff person after they leave the room. Really looking at the things that are in the room, all of these kinds of things that we don't necessarily think about as measurement really, but they should be measured and somehow at least qualitatively assessed and included in your project. And then balancing is something new for me in PQC worlds, and that is making sure we don't unintentionally change something. I mean, if you change the workflow and you've got more blood pressure cuffs available and you change how the room is set up and you change all of that, and then suddenly you end up with very, very unhappy patients because they're stuck in the waiting room, that's a balancing measure of, are people now becoming less satisfied with the system because it's not working very well. So trying to make sure you have those unintended things that are being assessed as well. A couple examples of measurement, just to make this a little more real. Outcome measures, again, we don't have any trouble with this kind of stuff. Percent of this, percent of that, people following up, people getting treated, correct treatments, that kind of thing. But the process and the balancing can sometimes give us a little bit of trouble. So a process could be average time in a waiting room. It could be percent of providers who took training for hypertension. We're definitely including that. So that's a great process measure. But notice it's not an outcome. It is a process. It's part of the change that could lead to the outcome we're looking for. Percent of women who were provided education. Again, we're including this in a lot of our initiatives, but it isn't an endpoint. It should be part of that outcome, a part of the whole measurement process with the outcome and the balancing. And then balancing examples, I mentioned already, patient satisfaction and staff satisfaction. I mean, if you have staff quitting because the process you proposed is just too hard, that's going to be a pretty serious impact, a negative impact on your facility. And then impact of treatment for non-hypertensive patients. So when we start to have a focus on certain patients, are other patients getting left by the wayside? And we're not giving them the kind of treatment they need. So some of these could be included, and the recommendation is you should be able to identify at least one of each of these in your initiative right now. So if you're thinking about this, what am I including? If you can't answer those questions because you don't have a balancing measure, maybe going back to your team and identifying what that should be for your next team meeting could be a goal. And then finally, measuring. We talked about the importance of measuring over time. And so here's an example of a run chart of whatever you're measuring. It looks like I chose measure pounds of red bag waste. I don't know if that's included in any of your hypertension initiatives, probably not. But whatever it is that you're measuring, you're going to try to measure it at many time points. And this is, again, very different than the world I came from with research, where we measured a pre and a post test. We didn't measure again and again and again and again and again over time. But finding a way to look at that, whatever that measurement might be, and be able to say, how am I going to measure this 20, 30 times over the course of this project? Because it is not going to be enough in quality improvement to do it a couple times. You will not be able to see true quality improvement. And this next example, my final slide here, shows exactly why that's true. So here on your bar chart, you see a pre and a post test. So the pre-test, it doesn't matter what we're measuring here. I'm just giving example, age before change. So we've got something that's happening. We want to improve that and we want to make it faster, better, whatever. So we measure it, then we do some training and things get better, right? So great. In the world many of us lived in, we're done. We did it. But when we look at how quality improvement evaluates this, we see an entirely different picture. So all three of the little run charts on the side show us the exact same bar charts if we were to measure it as pre and post. So you guys can see my arrow, right? Is that still showing up on the screen, like my little cursor? Okay, so here's our pre-test. Look at that. It measures, it's up here. It's at 70-something% or whatever on average. And at post, here I'm way lower. Great, fantastic. Here also, you see this pre-measurement and post-measurement. If you were just doing 2 points in time or an average or something, that's what you'd look at. And then finally in unit 3, again, the same exact results pre and post. But you can see very clearly that only one of these is really showing substantial and amazing change over time that looks like it's going to be sustainable, and that's unit 2. They're having this successive improvement over time, and it looks like there's some variation, certainly, as there always is, little jiggles and jumps here in the run chart, but over time you see that things are improving and looks like it might be on the improvement level going on out of the project. At unit 1, you might see some improvement. You might call this improvement, but it'd be pretty hard to say that that's going to be improvement. There's so much variation that, you don't know what a patient's going to get done one day to the next here. Maybe they'll have improvement and maybe it won't be really much change at all. So figuring out how to change, how to have more of a substantial, smooth change out would be very important for this particular run chart. And then finally, unit 3, again, looks like initially they had some training, they had a big push around this, they had some momentum, they improved, and then over time it kind of starts going back to where it was. But but your pre and your post test, again, show exactly the same thing. So I really, really urge you, if you're talking about quality improvement, that you are finding ways to measure whatever it is you're looking at over time, over a long period of time, and multiple points in time, in order to actually be able to measure quality improvement. And then my last slide is just my favorite picture of quality improvement. We're all really, really busy, especially these days. And so there's a lot of folks who probably didn't join our quality collaborative because they just didn't think they had time. And I want to thank you for making the time. And then as we see from our little Lego dudes, sometimes taking that moment, taking a breath and just thinking about quality improvement, we may actually be able to see some wheels that will help us in making things a lot smoother than trying to manage pulling this little block over these rough little Lego spots here. So thank you for not being too busy to take time to improve.
Thank you so much, Alicia. I appreciate your time, especially now that you're going to be trying to get on the road. So you can hop off and drive safe to Bismarck.
Yeah, thank you, everybody. And I'll be joining by phone, so I'll disappear, but I'll be there incognito. So
perfect. Bye. Okay. All right, so I just want to go over our quarterly report summary really quick. We had 4 teams turn in their quarterly report. So a huge thank you to those that completed it and submitted it. Everyone else, let's try to get more turned in next time for our next quarter. But to start off with our staff trained, we can see out of the 4, a lot have seen an increase in the percentage of their staff trained. And it's okay, we haven't reached our goal yet, but that is what we're doing here. And if everybody reached their goal on the first quarter of work, we wouldn't have much work to do. So each learning session, I'll put these up and we'll be able to hopefully see our trends moving towards our increasing and more people, more teams reaching our NSDPQC goals. On blood pressure compliance, this is kind of where we're sitting. I'll try and click through these so we can make sure we get all of our speakers in. We've seen an increase with deliveries with follow-up, and we're still working on reaching those goals. On education, this is where we're sitting. And then I just wanted to share a couple of the barriers that were submitted short staffed, having to deal with extra shifts, burnout, staff availability for screening, compliance, high turnover, influx of new staff, time constraints, a lot of the things we talked about with Tiffany already. But just know, if you're facing these challenges, you are not alone. Everybody, it seems across the board, are running into these barriers. But this is what I wanted to really focus on is our successes. One team reported 81% of staff trained, and that does include a new nurse that is currently in training. 60% of the staff, this is with the blood pressure training, and they have plans for more to attend in February. One facility said 100% of their December patients with hypertensive disorders had follow-up scheduled at the clinic 1 week post-discharge. That is incredible. They've seen increased provider buy-in for ordering proper follow-up. Nurses are using their knowledge, and there are plans in place to standardize protocols, order sets, and review education materials. So this is really exciting. The work is moving forward, and really excited for each of your teams to see what kind of quality improvement they see over this next quarter. Next, we will hear from Dr. Ramona Danielson. She is an assistant professor at NDSU Department of Public Health. She has 22 years of research and evaluation experience. Her areas of interest include maternal and child health, life course perspective, trauma-informed approaches, and self-healing communities. And I will stop sharing my screen, and I will let you share your screen. Ramona, thank you.
Excellent, thank you. 1 second here. Okay. Are you able to see the full screen and not my notes page? Okay, perfect. So I am here today to talk about the North Dakota PRAMS 2020 supplement that we included, which was experiences with COVID-19, and presenting on behalf of Grace Najau. The COVID-19 experiences supplement questions were added during the 2020 data collection cycle, and data from women responding to the survey in November and December 2020 included these COVID-19 experiences questions. 142 responses. We'll have more data for 2021. And these are women who had their babies in September 2020 or later. And as you may recall, North Dakota was not unusual, had our first confirmed case in March 11th. So these women did spend a significant amount of their pregnancies during the pandemic, beginnings of the pandemic. And among these women, 75% had only in-person prenatal care appointments. And the reasons for not having virtual visits, overwhelmingly, they just preferred seeing their provider in person. Some were saying that the virtual appointments with their provider were not available. There were some technology barriers for some women, not large proportions, but certainly an issue for those people. We did have 23% who had a combination of in-person and virtual visits, and 2% indicated that they didn't get prenatal care. Women were asked reasons for canceled or delayed prenatal care appointments, and they were able to check all, but not looking like cancellation or delay was a huge issue. 10% did have to cancel in order to self-isolate due to possible exposure or infection. 7% were afraid of being exposed. 7% said their provider's office was closed or had reduced hours. And there were challenges finding care for their children or their family members for 4% of women. But overall, looks like most women were able to do their prenatal care appointments according to the time they wanted. So these are questions about experiences these women had while pregnant, specifically regarding prevention activities. And they were asked whether they always, sometimes, or never did these activities. You see from the left, this is things that they were most likely to always do, very strong proportions who are always covering their coughs, washing their hands, using sanitizer, by the time you combine the always and sometimes, strong adherence. Wearing mask was about 74% who always wear their mask. When you get to the things that are more about interactions with other people, you start to see a little bit less adherence with always. Always having short outings was about 2/3, a little more than half that limited their outings or avoiding groups or staying 6 feet away, and about half that avoided visits. Always is a high bar. So, when you include the sometimes, you're always over 80%, but definitely that leaves, a good 20%, 10 to 20% of women who, while pregnant, were definitely going ahead and interacting with other people. And these were experiences while pregnant. I would call them kind of more stressors related responsibilities or job prevented them from staying home. That was about 2/3 of women. Other people did not practice social distancing when they went out. That was about 64% who experienced that. Many had someone in their household that had a job that required close contact as well. And then you have about 1/3 that found it hard to wear a mask, whether they had trouble breathing or claustrophobia. And then some difficulties finding sanitizer and disinfectants. And 14% said they did have a healthcare provider tell them they had COVID-19. 13%, someone in their household was told they had COVID-19. And then a small proportion who had trouble getting or making masks or cloth face coverings. While they were in the delivery room, 92% said they had their husband or partner with them in the delivery room. And it's just interesting to me to think what a generational change that is. Even, just thinking of my grandmother's generation. What a wonderful shift it is that the husband or partner it's just the norm now. 5%, some other family or friend, and but less than 1% said another support person. So really the vast majority had somebody in the room with them. Less than 1% weren't allowed that. The ones who had another support person, that they mentioned a photographer or having their mother and partner, or mother and the father of the baby. Nobody did mention that they had a doula in this sample. After delivery, not quite half recalled being given information about how to protect their baby from COVID-19 at home. 44% did wear a mask when other people came into the hospital room. So less than half there. 40% were given information about how to protect their baby during breastfeeding. 15% wore a mask while breastfeeding. 14% wore a mask while alone caring for the baby in the room. 8% said their baby was tested for COVID in the hospital. And then a small proportion of women who had trouble getting a visitation from a lactation specialist or pumped breast milk to avoid getting their baby infected. And 2% were separated from their baby to protect the baby from COVID-19. And that, as we know, is a pretty significant experience to have that baby separated. The impact of COVID-19 on babies' routine healthcare, those well child checks, and for the most part, these looked like they were able to stay on track. 5% were canceled or delayed. 4% did have immunizations postponed. And while these are small proportions, of course, we don't want any babies to be missing their immunizations or their well child checks. And really not a lot of experience with virtual appointments, with their visits being changed to virtual appointments. Looking at the mother's postpartum appointment, vast majority were in-person appointments, 81%. Only 1% were virtual only, and then you had another 9% who did both. And thinking about some of the other priorities of North Dakota Department of Health, still 9% of women who said they didn't do a postpartum visit for themselves. So we certainly would like to see that number go down. stressors due to the COVID-19 pandemic. So this did not restrict to just while pregnant. So this would have been from March forward, pretty much would be while pregnant, but would also include the time period when after the baby is born and before they do the survey. So nearly half said they felt more anxious than usual, and 29% felt more depressed than usual. And I know that is mirroring a lot of data that's coming out about the mental health effects of the pandemic, but these are caregivers of newborns, so definitely of concern with regard to, you know, any impacts that might have on serve and return and attachment and all those types of things. So definitely important to know those experiences. Interpersonally, 20% said that they were having more verbal arguments or conflicts than usual with their husband or partner. 3% said that there was more physical, sexual, or emotional aggressiveness towards them from their husband or partner. Financially, and these could probably kind of be categorized all together, but 28% had a household member or themselves that received unemployment benefits. 26% had lost their job or had a cut in work hours or pay. 22% had other members of the household with that circumstance. 16% had problems paying the rent, mortgage, or other bills. And of course, you know, all of these are high stressors while pregnant, and ideally, you know, we wouldn't be elevating stress while pregnant, because we know that there can be implications from that on development. 31% had to spend more time than usual taking care of children or other family members, so some added stress there. Loss of childcare or school closures made it difficult to manage responsibilities. As you recall, 65% said they were working outside the home. I would say I was able to work inside the home, so I kept working, but was fortunate to not have to leave the home to do that. 10% worried about food security, that their food would run out. 8% had to move or relocate. 2% became homeless. So, you know, again, that's a small proportion, but also, you know, still very concerning for that proportion of women. So just a few notes of some other data that Grace and I have worked on, and these are insights from some analysis that we've done. We're working on a manuscript for this. We did matching of birth records with the Department of Health COVID-19 testing data. So we were looking at whether infants born to pregnant people in North Dakota with a positive COVID-19 test between April and December 2020, whether they had worse birth outcomes than infants born to pregnant people without a record of a positive test. And of course, the way that we're saying that is because some people could have been positive and we wouldn't necessarily have a record of their test. Or if here in Fargo, they happen to test in Moorhead or elsewhere. We did, not going into a lot of details methodologically here, but we did do some analysis of previous data and trends to be more confident in what we thought the data was telling us. So 311 North Dakota women had a positive test record while pregnant in that 9-month period, which is very similar to the period where our respondents would have been pregnant. And interestingly, that's about 3.5% of birth records, whereas 14% of moms in the survey told us that they had COVID-19. So not sure, and specifically the question is that a healthcare provider told them. So interesting to think a little bit more about that discrepancy. We did use propensity score matching to control for demographic and health-related characteristics that themselves could potentially influence the likelihood of exposure to COVID-19, or that could maybe impact birth outcomes. And when we did controlling for everything, ultimately, we found that having a positive COVID-19 test during pregnancy did not have a significantly different, these women did not, or infants born to these women did not have significantly different birth outcomes than infants born to those without a positive test. So there is other research that has confirmed that. And then, of course, we do know still that in cases where a mother gets you know, COVID-19, it is a higher rate of severe outcomes or risk for severe outcomes. But you know, within our you know, our women who gave birth during this time, the outcomes for the infant were not significantly different. We do know that things like the added stress and other factors, we may see some of those impacts past this point of time. But key takeaways for just kind of the overall data here is that most of our prenatal care visits did continue to happen in person. Women were more likely to always engage in those hygiene-related prevention measures and less so in those physical distancing measures. 2/3 of women had responsibilities for a job that prevented them from staying home. 14% were told, as I mentioned, that they had COVID. Nearly all women had a support person in the hospital delivery room, but that 2% who were separated from their baby is, definitely impactful for them. Less than half used COVID-19 safety measures while in their hospital room. 5% of well visits were canceled or delayed, and 4% of immunizations. So, definitely we'd want to make sure that we get those kids caught up. 9% of women didn't have that postpartum visit. The higher anxiety and depression than usual, more interpersonal conflicts with that additional aggressiveness for some. And then those impacts on basic needs and the stresses that came with the lost job or cut in pay. So those are the insights that I wanted to share. This is our first dive into that COVID-19 data. And when we have a little bit larger N, we'll be able to really explore, I think, in more detail or start doing some deeper dives on the data. So Grace has her contact information here. And I'm happy to try to answer any questions if there are any. But thank you for giving us the chance to share some of that data with you.
Thank you so much for sharing that with us. So that was all North Dakota data. Now we're going to hear from South Dakota from Caitlin Strasser. She is the maternal child health epidemiologist. Oh gosh, I start talking and he thinks he needs to talk too. I'm sorry. Just like Alicia, I mean, you can give him as much TV and snacks and be prepared, and he has to sit on my lap. So she is the maternal child health epidemiologist for the South Dakota Department of Health. She works on data for a variety of programs and services across the Office of Child and Family Services, including infant mortality, maternal mortality, and the Maternal and Child Health Block Grant, WIC, and Pregnancy Risk Assessment Monitoring System, the PRAMS data. She is passionate about helping others understand the data so that it can be used to inform decision-making around public health programs. So I'm going to go on mute now, and Caitlin, I will let you take over.
Thank you. Can you guys see my screen okay in full view presentation? Perfect. A lot of this will be very similar to what was just presented. I just had this slide in here. I think most of you are probably familiar with PRAMS, but if not, it's a study of the population-based survey of the CDC, and in South Dakota, we surveyed mothers 2 to 4 months after delivery to assess maternal attitudes and behaviors before, during, and after pregnancy. And we use this data for a variety of purposes in our own programming and services to support our block grant. And then we also share it widely with various partners and the tribes to aid in their own needs assessments, grant applications, and to support other programs and policies. And in the past 10 months, we've received both our 2019 and 2020 data back from the CDC. So we're excited to now have 4 years of CDC funded PRAMS data. So if you're interested, the data from our 2017 through 2019 surveys are on our website, and we're reviewing our full report for 2020 right now, and that should be up there soon as well. We cover a variety of topics today. I'm only going to be covering our COVID-19 supplement and then a little around substance use, as I thought that might just be helpful, knowing that you've been discussing that a little bit as potentially your next topic. So, but if you have questions or want me to present on any of this other data at any time, just let me know. So in mid 2020s, South Dakota PRAMS was able to add supplemental questions about COVID-19 experiences to the existing questionnaire. We captured this data from July through December 2020, so we currently have 6 months of data to report. These questions are exclusively about experiences and do not address vaccines yet. Those questions were added later and will be available with our next year of data. So these next few slides will provide an overview of the questions we asked moms about. We did break this down by the responses overall and broke it down by our 3 race strata here, which I wanted to show you. So by white, American Indian, and mothers of other races. And just a little caveat, because this is only 6 months of data, you'll see the numbers we have are pretty small and should be interpreted with caution. Those specifically where we've identified that are marked with a little caret, a little arrow pointed up, and you may also see blanks if there were no responses to a particular question, or little asterisks if the number of responses was too small to report. But some of this is really interesting, broken down by race, so I wanted to show you these data tables for what we do have. So they're going to be the exact same questions as what was just presented. It's a standard supplement set of supplemental questions. So the first question captures types of prenatal appointments during the pandemic, and we see that not only does the breakdown of visit type vary by our different race strata, but the percent of moms not receiving prenatal care also varies by race. So about almost 9% of American Indian mothers reporting they did not have prenatal care, compared to 2.4% of moms of other races and less than 1% of white mothers. Individuals who only had in-person prenatal care appointments were asked about reasons for not attending virtual appointments, and the responses here are shown below. We see things like access were prominent barriers in American Indian communities, and not just the lack of virtual appointments, but also we see lack of phone, cell minutes, computer, or internet to have a virtual visit. We asked mothers for reasons if prenatal appointments were canceled or delayed. And here we can see the top reason overall was the office being closed. And this was most prominent among, again, our American Indian mothers, as were some of the data around social determinants of health. They identified lack of childcare and transportation as being significant barriers. And I know most of us on this call probably understand that and have seen that. We asked mothers about certain behaviors, and again, if they always, sometimes, or never practiced them during the pandemic. I only showed here behaviors that they always said they practiced. So here we see the overall responses, and this is with all races combined. We can see the behaviors that were always practiced by the most moms included covering coughs, washing hands, and using hand sanitizer. So interesting to compare North Dakota, South Dakota. It was very similar as I was looking at the previous slides from North Dakota, with more of these hygiene things having a higher percent of always being practiced. And I think it will be interesting too when we get our next year's round of data to see how these have changed over time, if people are less likely to practice them or more likely. So this figure again shows all races combined and highlights different experiences related to COVID-19 that mothers went through during pregnancy. Over half of moms experienced not being able to stay at home because of job responsibilities, as well as mothers of their members of their household having contact, or others not social distancing. This question, who was with you in the hospital delivery room as a support person during your labor and delivery? Total was, husband or partner was in the room at 85.4%. I also found it interesting that we had very few responses around a doula. In South Dakota, there were just a few there that said that they'd had one in their room. These 2 questions assess experiences with healthcare for both baby and mom, and we can see in the top table how baby well visits and immunizations were impacted by COVID-19, particularly among our American Indian mothers. And in the table below, what I find most striking is the percent of moms not getting a postpartum visit at all. This ranges from about 4% in our white moms to about 28% of our Native American mothers. I found that statistic pretty striking there, but as I went back and looked at other years where we didn't have COVID around, it was actually very similar, the amount of moms who reported not having a postpartum visit. And then the final question I put on here was around experiences due to the pandemic. We can see that overall, many of our moms were experiencing anxiety. There were also changes in the amount of care moms were providing and challenges like losing jobs or having problems paying bills. So to summarize, we know that pregnancy and delivery experiences have been impacted by the pandemic. And now we're starting to have data that captures that for moms in South Dakota. So we are continuing to collect this and the other COVID-19 vaccine supplement. And so we'll continue to share that too as it becomes available. Just very briefly, I wanted to show you a few other things. Like I said, I know that there's been some discussion around your next topic, particularly with substance use and maybe meth. So I just have a few slides here to show you some trend data from 2017 to 2020 that might be helpful as you make decisions, or maybe you're applying for, applications for funding. So most of the indicators and params for us have not increased or decreased a statistically significant amount over these 4 years. However, most of the indicators that have revolve around substance use, particularly tobacco, alcohol, and illicit drugs. So this first trend shows improvement. The percentage of mothers who smoked 3 months before pregnancy has decreased over time. As you can see here, from 23.6% in 2017 to 18.8% in 2020. And this decrease occurred among all 3 race categories, but there were still some differences between races. While smoking cigarettes has decreased, the percentage of mothers who used e-cigarettes or other electronic nicotine products in the last 2 years has increased over time from 6.3% in 2017 to 9% in 2020. And the use of e-cigarettes does not vary by race. As you can guess, mothers who are younger than 20 years old were the most likely to have used e-cigarettes or other electronic nicotine products in the 2 years before the survey. And about 30% of mothers under the age of 20 reported that they had. Mothers who drank alcohol, mothers drinking alcohol before and during pregnancy is something that we watch closely. We know that overall, South Dakota has high rates of alcohol use and binge drinking among various groups. So the South Dakota mothers who drank the last 3 months of pregnancy has increased over time from 8.3% in 2017 to 13.3% in 2020. This is kind of an interesting indicator. So mothers who drank the 3 months before pregnancy, which isn't shown here, but we ask about that too. Those mothers are more likely to be white, non-Hispanic, between ages of 25 to 29, had greater than a high school education, were married, and had a higher household income. But when we look at the drinking the last 3 months of pregnancy, what's shown here, there weren't any significant differences among any of those demographics, except that the mothers had a lower income. And the percentage of mothers who used any illicit drugs in the month before pregnancy has also increased from 8.4% to 11.8%. These mothers were more likely to be a Native American, younger, have less education, not be married, and reported making less than $16,000. Grams also asks about illicit drug use during pregnancy, and that indicator has increased over time from about 3.3% in 2017 to 6.9% in 2020. And finally, I wanted to show you just 2 additional slides on drug use we capture in params. So part of our core survey has some general questions about drug use before and during pregnancy. And the data on these next 2 slides is from 2018 and 2019. I just didn't have time yet to update them with the 2020, but I did take a look, and I'll just point out a few things. So women were asked if the month before pregnancy they used any of the following drugs. And you'll notice that there's everything from, over-the-counter pain relievers to illicit drugs on here. So about 70% of women said that they took some over-the-counter pain reliever. 3% took a prescription pain reliever, 2% took a stimulant like Adderall, 7 to 8% used marijuana or hash, a little less than 2% used amphetamine, and 8.5% responded that they had used any illicit drug the month before pregnancy. We did ask about some other drugs like methadone, heroin, cocaine, and others, but the prevalence rates for these were not high enough to report. And similarly, the moms were asked if they took any drugs during pregnancy. So for most of the categories, the prevalence decreased from the previous slide where it was drug use before pregnancy. So that was good to see. But one other difference I wanted to point out is that we are starting to see our marijuana use before and during pregnancy increase. So when I looked at our 2020 data, I saw that 10.3% of mothers reported marijuana use before pregnancy, which was higher than the last 2 years, and then 5.9 reported it during pregnancy, which again was higher than the past 2 years. So these were the highest responses we've seen from doing PRAMs, and we'll continue to monitor this closely, especially as laws around marijuana are changing in South Dakota. So I think it's something we'll keep a close eye on. I didn't put any data from our opioid supplement in here, but we have even more data that's really focused on opioids if you are ever interested in that topic around use and beliefs around opioid use during pregnancy. So that's all I have today. Thanks again for letting me present. I'm happy to take any questions, or if you want to contact me afterwards, happy to chat with you too.
Perfect. Thank you so much, Caitlin. Next, we're going to hear from Kiamaya Filson. She is the Health Equity Immunization Coordinator out of the Health Equity Office at the North Dakota Department of Health. She's originally from Greensville, South Carolina, but now resides in Bismarck with her husband. She works to improve the vaccination rates amongst the special populations of North Dakota by providing education, assisting in forming materials, and through the coordination of pop-up clinics around the state. She's got some really great information for us today. So Kiamaya, I will let you share your screen and take over.
All right. Okay. Can you all see that, the like puzzle pieces? Okay. Hi everyone, I'm Kiamaya Filson. I'm the Health Equity Immunization Coordinator out of the Health Equity Office, like Morgan mentioned. And so this presentation is mostly focusing on my work with the NFI population, which is the New American Foreign-Born Immigrant population. I think when people think of North Dakota, they kind of think of the standard, white rural individual. And I thought of that before I came to North Dakota. And to my surprise, when I got here, there's a lot of diversity within the state. And so I think it's important to think of that when we're dealing with patients and interacting, and then, think of some of those cultural experiences that they have with them to ensure they have a good care. And then also, especially with COVID, understanding some of that history so that they can be comfortable and confident when they're choosing to get vaccinated. So this is taken from the ND Compass. It's the person of color by county. And so North Dakota has close to 20% of people of color within the state. And we're going to focus on these 5 major cities: Bismarck, Fargo, Grand Forks, Minot, and Williston. When I first started, I thought mostly of the people of color being on the eastern side of the state in Fargo. But I came to realize that there is a large amount of people of color on the western side as well, especially due to job opportunities and seasonal job opportunities. And we see that Williston has the largest population of people of color in the state, which was surprising to me because I would have expected that to be Fargo, especially, being so close to Minnesota and things like that. And so, like I mentioned, the 5 focus cities will be Fargo, Grand Forks, Bismarck, Minot, and Williston. And Fargo's in Cass County, which has a 19% of population of people of color. Grand Forks in Grand Forks County has a 19.7% population of people of color. Burleigh County has a 14.3% of people of color. Ward County, which has Minot, is 20.4% of people of color. And then Williams County, which has Williston, is 24.9% of people of color. And some of the major ethnic groups in North Dakota are the Somali population, Ethiopian, West African populations, South Sudanese, Nepali, Kurdish, Liberian, Hispanic, and also Filipino. I didn't put up here, but that is like one of the largest groups of people of color in North Dakota. And each of these groups, of course, have different cultural backgrounds, and they pull their information and they have trusted resources different across each of these groups. And so some of the primary hesitancies are things that I work on through my job. So I've tried to see what some of these hesitancies are, and then try to get ahead of these either pieces of misinformation or things like that to combat that, to, like I said, make people confident and comfortable when they're getting vaccinated. And of course, not just COVID, all vaccinations, but COVID is kind of a big deal right now. So it's been COVID for the most part. So one of the top hesitancies is fertility and pregnancy and breastfeeding. And so family is a very important aspect to a lot of these cultures. And that I think is, true for across the board. And so something that's threatening that, especially with like misinformation around the COVID-19 vaccine, something that is going to be questioned and avoided. And so in my work, a lot of the leaders are mostly men. So I speak most to men. And one of the biggest things I've heard is their libido and their sex drive, which was interesting to hear. But I also know just from their reportings that people, or especially the women, are worried that it will reduce their fertility. They'll have, some of these stillborns, low birth weights, things like that. I think it's important to realize that pregnancy is an indication for vaccination outside of COVID. And they are at that immunocompromised state. And so they're at a higher risk for those severe illnesses from COVID-19. And some of the issues that they are worried about being connected with the vaccine are actually connected with serious illness from the virus itself. And so I think sometimes people just think of vaccination versus not vaccination when it's really vaccination versus virus. And so that, creates hesitancy within the groups with a false sense or measure of risk-benefit analysis comparing the vaccine against the virus. Another big hesitancy or source of hesitancy is government mistrust. And so we know there's a large history or a long history in America of, people of color being mistreated through, different medical processes or, just mistrust across the board, whether it's like personally in a doctor's office or, systematically. And so often people of color feel that the government doesn't have their best interest in mind. I know the CDC has, made some changes over the past couple months that have made people question if they have their best interest in mind, and people don't completely understand the process, and that scientists are keeping up with COVID as best they can. And the constant changing protocols is, really causing some hesitancies and mistrust in the government. And so it's our job to make sure that we explain why the changes are happening, the science behind the protocol changes as best we can, so we can kind of combat that. A big thing was also the vaccine development timeline. It was called Warp Speed, Operation Warp Speed, and I don't think that helped them in the long run, because it kind of seems like they're just, cutting corners and safety protocols, when in reality it was kind of just a lot of the red tape and paperwork that was cut. And I don't think the average person actually knows the standard vaccine development timeline, but we, kind of have an understanding that it didn't take the couple of months to a year that it took to make the COVID-19 vaccine. And so it's our job to be able to relay that information of what actually went into Operation Warp Speed, and what things were actually cut in order to get the vaccine out, and why it was a priority to get the vaccine out as soon as possible, to, kind of ease some of that hesitancy. Another source of hesitancy is social media spread of misinformation. And this has been a really big pusher of a lot of the misinformation that's out there. So there's tons of pieces of misinformation, and primarily with these NFI groups, information from overseas that doesn't necessarily apply to vaccines and treatments in America, that has influenced how they see their treatment and the vaccines in America. WhatsApp is a really popular platform for a lot of these groups. And even we were connected through WhatsApp to help, send out messages and alerts and reminders for our advisory boards and things like that. And sometimes they send me information that they've gotten, and they ask me, well, what do you have to say about this source, or this piece of misinformation that I'm seeing. And so I've seen firsthand, some of the things that circulate on WhatsApp and Facebook and things like that. And then just in conversation and our, meetings that we have with some of these groups, they bring up some of these things they've seen on social media. And I think a big thing that helps them spread so quickly is that misinformation can spread very quickly if there's even a little piece of truth in there. And so specifically, one of the biggest ones was the fertility myth, and that the vaccine, caused low birth weight and stillbirths and all that. And a source for that connected like the protein, protein that was necessary in developing a baby with the spike proteins that were developed in the vaccines. And the small piece of truth in that was they're both proteins, but then beyond that, it was no connection. And so it was a piece of misinformation that took a little piece of truth and kind of, built a big piece of misinformation that widely impacted how people make their decisions on vaccines. And then another piece is community testimonies, which has a large effect on the community. And it's something that we're actively trying to combat. And so if the governmental voices and public health voices and official voices are trusted, then people turn to social media and also community testimonies to, get some information and fact. And those are their trusted voices. And these voices hold a lot of weight, especially if they're coming from leaders. And word can spread quickly by word of mouth on certain side effects, how certain doctors interact with people, where to go for treatment, things like that. And so a big thing that I've seen has been people have been vaccinated and then they tell of their side effects and connecting them falsely with the vaccine. And that has put fears into community members as well. And also the rate of reinfection or breakthrough cases has also been a big deal. So if someone's neighbor got the vaccine and they were infected naturally with COVID, then that has caused, a lot of mistrust within the community because they feel like if the vaccine is going to help me not get COVID, then what's the point of getting the vaccine? And so we've tried to combat this a lot. We have a weekly radio show that's being developed where we have leaders come on and give their personal testimonies, and we give fact with those testimonies to make sure that we are combating those negative community testimonies with fact from leaders that have information, have the best interest in mind for the community as a whole. And so now how can we help people make a decision about this vaccine? And I think it's important to focus on messaging that works. And so right now, boosters are kind of the highest level of protection that we can get. And so I think it's also important to note that before, in the beginning of the pandemic, it was get your vaccine so you don't get COVID. But now it's get your vaccine so that you don't have to go into hospitalization, have that serious illness and that death. And so it's not just a matter of your primary series and that's it. We have data that shows that you're at your highest level of protection with your booster. And so it's necessary to stay up to date with our vaccinations. And that is including getting your booster when available. It's also shown that if enough people are vaccinated, we can prevent 100,000 deaths or more. And so it's showing that even if you believe that you are not at the highest risk for COVID, you can still be a method for it to spread and mutate, because as the vaccine spreads from person to person, it has the ability to mutate and continue to create variants. And so you making your individual choice has, ripple effect up to 100,000 people. And so you have the power to influence a lot of lives in getting vaccinated. It's also important to kind of give that professional aspect to it. So almost all doctors have been offered the vaccine have taken it. It's not just something that people or the government is offering to immigrant populations or people of color. People who you think are of high standing are also taking it. It's not just offered to a certain group, but this is what's in the best interest for all people. Going into vaccine development, the speed of the vaccine's development was a result of cutting the red tape and bureaucracy, not cutting corners or bypassing safety and precautions. And so reassuring them that the speed of the vaccine development was in the best interest of the people. We were in the pandemic, it was necessary to get it out as soon as possible, but as soon as possible with all the safety protocols being met. And so it's important to understand that vaccine development and also be able to accurately communicate it to the people as they have these questions. Going into that, so the phase 3 trials for the authorized vaccines enrolled tens of thousands of people, and none were hospitalized or died. And so this shows that that is one of the biggest safety protocols that is necessary in vaccine development. And this shows that in those testings, there were no serious adverse events reported even 2 months out. And so there was serious monitoring, and we were able to reach a large number of enrollment people to actually test and see if the vaccine was effective and safe in a large group of people in real life situations. And then getting the vaccine allows people to take control of their health. You don't know how COVID will affect you. And some people are willing to run the risk, but it's a really unnecessary risk to run. We know how the vaccine will affect people, and we know how the booster can, boost up your protection against COVID when you don't know how the natural infection will affect you. And so another approach that is easy to have conversation with people when you're talking about the vaccine. I know COVID has kind of just run people down. Where people are kind of tired of talking about it. It's just been a thing for 3 years now, but the ease approach is something that you can use to have friendly conversation about the vaccine and have a confident conversation when you're doing it. And so it's an acronym for elicit, acknowledge, share, and explain. And so you elicit the main concern, you acknowledge the concern without judgment, you share your commitment to health and safety, and then you explain what the science says about that concern. And so, for example, if you had a patient or just anybody like a family member as well who had a concern about the vaccine due to a fertility issue. So you would begin by just assuming that they want the vaccine and you show confidence in its safety and its effectiveness. And so I would begin by, hey, when are you going to get your vaccine? Do you need help with signing up? Or I can help, transport you to the clinic if you need it. And they would say, I don't plan on getting the vaccine. And so then elicit the main concern, like, oh, why? Like, is there a main reason you wouldn't want to get the vaccine, or do you just kind of not want to get it? And so then they would tell me, I've heard it's connected with fertility issues, and I just want a family in the future, so I'm not going to get it. So then you would go and acknowledge the concern without judgment. So I say, okay, I understand that. I've also, seen that information spreading around, and family and fertility is a very serious matter. I also have that's one of my things that I want in the future is a family. And so it's normal for you to have some concerns and want the best possible safety outcome for you. But now you share your commitment to health and safety. With that being one of my things that I want in the future, I also want to make the best decision right now for that future. And I know that COVID is a serious thing, and I got my vaccine. And I did my research to see if this information was true or not. And then you go into explaining what the science says about the concern. And so then you go and show that there have been, studies on pregnant women with the vaccine. There's no difference between vaccinated women and unvaccinated women in the rates of stillbirth and premature births and things like that. And so that, kind of helps guide the conversation. And it gets out the true reason why some people are hesitant to getting the vaccine. Without getting into political aspects, without getting off on tangents. It helps guide the conversations to show that your goal is to help them make a confident decision in getting vaccinated. And of course, there are some people that are really set on not getting the vaccine. And so this is really for people who actually have those genuine hesitancies, and just due to lack of education or lack of confidence to help guide them in that decision. And so there are collaboration opportunities that we can do with community members to help them get to that confident level to get the vaccine. And so I mentioned that Maureen mentioned in my intro that I do trainings and educational outreaches to community members. And so Train the Trainer is one of those things. And it's a presentation that goes over some of the common myths that are prevalent within some of these communities, and it gives the facts directly to them. And then I supply them. We also go over the ease approach, and then I give them the slides so they can then go out and do the presentation in their communities if they wanted to. And that has been really effective. We have contract with a group on the eastern side and the western side of the state, and they have leaders and care coordinators, and we've been able to equip them with information and materials necessary to combat some of these pieces of misinformation. And they've gone out and they've helped organize pop-up events. And so these events are an equity approach to vaccination. So some people we know have hesitancies in going into clinical settings. They have bad histories with certain medical professionals. And so these pop-up events occur at community events or non-traditional settings where people feel more at ease. And we also try to make them along their regular like daily route. So one we have coming up tomorrow actually is in Minot at a cafe. And so people are able to come in, get vaccinated, and it's not necessarily in a setting that may give them anxiety or kind of, make them hesitant to come in. So it allows them to, get a service and also get vaccinated. We've also had them at community events surrounding like religious holidays, so like Kwanzaa or Eid for people who practice Islam. And so these events have really provided, good opportunities for these communities to come and get vaccinated in a comfortable environment. Panel discussions are also beneficial because people still value that professional voice. So doctors who specialize in whatever the topic is. I'm sorry if y'all hearing that barking. That's my puppy. I don't know what she's barking at. She was asleep until I started talking. So panel discussions give that professional voice. It's one thing to come from someone who works from the state or someone who, still is specialized in this work, but it's another thing to come from a doctor who has dedicated their life to doing this work. And I also think it's important to think of our non-COVID community interaction because that is the basis of the trust. So I think in starting this work, I realized that it's important to have already had that level of trust with the community so we could go in and give this information. And if we don't have that trust already developed, then when we try to present new ideas or things such as the COVID vaccine will be, pressed back against a little bit and have a little bit more extra work to do. And so I think this pandemic has exposed the fact that we already have to have that level of trust and connection in our communities, regardless of, the pandemic and the future things that may come about. And that is all. Are there any questions or anything?
Thank you so much, Kia Maya. And I forgot to say happy birthday. Thanks for spending part of your day with us. Hope you get to celebrate tonight a little bit. Next, we are going to hear from Dr. Ashley Briggs. Let me just get this pulled up. She is a clinical associate professor at Sanford School of Medicine at the University of South Dakota. She's currently serving on the South Dakota Maternal Mortality Review Committee, the Sanford Maternal Race and Ethnic Equity Task Force, and on our leadership team. I shortened it down. I know we've heard from her before, but let me get my screen up and I will let you come off of mute.
Thank you, Morgan. I think she's getting my slides ready.
1 second, sorry.
Oh, that's just
Here we go. I have 2 screens, but I still feel like I could use a third.
Oh, no, that's fine.
All right, there you go.
Thank you. So, so with our project that we're working on, this was really timely that California's Maternal Quality and Care Collaborative did an update of their toolkit the end of 2021. And so I'll be touching on the first part of this, and then Dr. Lessard will be talking kind of on the second part of the updates that they did in this toolkit. So we can go to the next slide. So in this update, they kind of touched on kind of 4 big areas in this. So they did a summary of changes from improving the healthcare response to preeclampsia from their 2013 toolkit. So 4 main areas that they addressed were they expanded the scope to address all of these hypertensive disorders of pregnancy. They wanted to align with ACOG's definition of severe hypertension with the explanation for consideration of treatment at lower borderline values of blood pressure. They touched on low-dose aspirin for the prevention of preeclampsia. And then they also touched on long-term follow-up for hypertension disorders of pregnancy. Go to the next slide. So maternal hypertension in the US, these hypertension disorders of pregnancy, we have been seeing a rise in those. and they include a gestational hypertension, preeclampsia, eclampsia, and also chronic hypertension. And so they just included a graph kind of again showing the rise all the way back from like 1993 to their data in 2014. Well, the next slide. So I was able to include, the bottom right corner shows the slide from their quality collaborative, and they included pregnancy-related deaths by all cause from 2008 to 2016. And I wanted to go, it's that third bar graph, which is HDP, so it's the hypertension disorders of pregnancy. And they found about 13% of their deaths were related to that. Up in the top left corner is South Dakota's information from our Department of Health website. So from our causes of pregnancy associated deaths from 2010 to 2017, our hypertensive disorders of pregnancy, we had about 3.9% of deaths related to that. And then from one of the medical journals from North Dakota, they reported from their MMRC group from 2008 to 2017, overall they had 30 deaths over that time span. Half of those were from motor vehicle accidents, 3 were from suicides, 1 was a homicide, and then 3 of the most frequent medical causes of death were cardiovascular deaths, thromboembolic events, and a brain aneurysm. But they commented that not one cause was from kind of the 3 most common medical reasons, so hypertension, hemorrhage, or sepsis. So I didn't get kind of, I guess in that journal article, they didn't report more specific numbers, but again, just interesting, I guess that none were from hypertension. So we'll the next slide. So when this new toolkit commented on preventing stroke from preeclampsia and kind of looking at this borderline severe blood pressure range, they referenced a study that looked at 54 patients that had preeclampsia from stroke and pulled out this borderline severe range. And so in this slide, they have in the boxes to the right, you can see 2 patients that had systolic blood pressure between 155 to 160. And then they had 4 patients that had diastolic blood pressures between 105 to 110. So kind of just below that range where we would normally be treating patients for that severe range blood pressure. They said these 6 patients, or 11%, would not have been considered for treatment under the current guidelines. Again, that 160 over 110. And they said it is possible that treatment of these patients may have prevented them from suffering a devastating hemorrhagic stroke. So the theoretical risk of inducing severe hypotension has not been reported to any great extent. And this data emphasizes the fact that severe range of blood pressure will often fluctuate and that stroke can occur at these borderline severe ranges of that 155 systolic or 105 diastolic. So they said this merits consideration of antihypertensive treatment in these cases. So again, they're defining this borderline severe range of blood pressure greater than 155 to 159 over that 105 to 109. So we can go to that next slide. So in this toolkit, they have a section that they call borderline severe blood pressure recommendations. And they're recommending that if your patient comes in and has blood pressures in this range, that the provider should be notified. They should come and evaluate the patient, and the patient should be on continuous electronic fetal monitoring. They do recommend inpatient observation for a minimum of 24 to 48 hours. And the vital signs and symptoms assessment should be done every 2 hours for a minimum of 24 hours. They recommend serial assessment of the serum labs at least daily for 2 days. They, over in the box to the right, they say consider antihypertensive therapy and magnesium sulfate, again, if they're in this borderline severe range blood pressure. So again, at this time, ACOG has not added this to their recommendations, but this is coming out of that CMQCC toolkit. And it's referenced at the bottom there. So next slide. So the objective of treating hypertension is to prevent congestive heart failure, myocardial ischemia, renal injury or failure, and ischemic or hemorrhagic stroke. And controlling blood pressure is the optimal intervention to prevent death due to stroke in women with preeclampsia. They have also added in this toolkit, once we achieve that target blood pressure, they defined what that target blood pressure is, and then they gave us guidelines for how often we should be monitoring the blood pressure once that target is achieved. So they said once that blood pressure threshold is achieved, we should be checking it every 10 minutes for 1 hour, every 15 minutes for 1 hour, every 30 minutes for an hour, and then every hour for 4 hours. So that was something new, giving us guidelines again on how often to monitor it once that target blood pressure is achieved. And go to the next slide. So magnesium sulfate, I think we always have to remember, is not an antihypertensive medication. Again, if that blood pressure is elevated, we need to be using our antihypertensive medications. The primary effect is via a CNS depression. It improves blood flow to CNS via small vessel vasodilation. Magnesium sulfate is for seizure prophylaxis and is indicated for preeclampsia with severe features and severe gestational hypertension. So all cases of severe, that greater or equal to 160/110, sustained, so lasting greater than 15 minutes or more, hypertension regardless of that classification. We should be using the magnesium sulfate. Next slide. The rate of seizures in preeclampsia with severe features without magnesium sulfate is 4 times greater than those without severe features. So they give the example of 4 in 200 versus 1 in 200. In an asymptomatic patient, they said 129 women would need to be treated to prevent 1 case of eclampsia. And if your patient had symptoms, 36 women would need to be treated to prevent 1 case of eclampsia. So if your patient had a headache, blurred vision, photophobia, hyperreflexia, or epigastric pain. If the patient has a high BMI, especially greater than 35, then the antepartum level of magnesium may remain subtherapeutic. So especially considering doing like a 6-gram load of your magnesium instead of 4 grams, and then your 2 grams per hour. For women requiring cesarean delivery before the onset of labor, the infusions should ideally begin before surgery, be continued during surgery, as well as for 24 hours afterwards. I included this because sometimes it seems like magnesium will be started after the C-section, or I've seen some cases where it will be turned off during the C-section. And really, I think some providers feel like it may increase the risk for hemorrhage, and there have been studies, and they have not seen an increased risk for hemorrhage. And all you're really doing is letting that patient become subtherapeutic in that magnesium level. So again, recommendation is to start it before the C-section and continue it during the C-section. Next slide. So in the setting of severe preeclampsia, magnesium sulfate should be administered upon diagnosis, continued intraoperatively, and until 24 hours after birth. ACOG does have a document, it's the hypertension in pregnancy, and it's their task force in hypertension. I included the reference at the bottom, but it's very nice. It includes recommendations and gives their quality of evidence, and then the strength of the recommendation, and it has lots of questions, and then you can again look up that level of recommendation. But it comments for women with preeclampsia undergoing cesarean delivery. It should be continued intraoperatively, the magnesium sulfate to prevent eclampsia. And then for women with preeclampsia, the administration of intrapartum magnesium sulfate to prevent preeclampsia is recommended. So again, if you have questions on, different timing of magnesium, things like that, this reference is very nice to look things up in. And go to the next slide. So with risk factors for preeclampsia, and I listed the ACOG practice bulletin, they did add 2 new risk factors for this. The 2 they added were assisted reproductive technology and obstructive sleep apnea. So when you're seeing your patients for the early OB or new OB visit, and you're kind of assessing them for risk factors, just to be aware, there's 2 new ones that were added. And go to the next slide. And then as we're looking at, should your patient be placed on aspirin, this is a list that looks at risk factors that can be in the high category or the moderate category. So if they have a risk factor from the high category, they just need one of these risk factors. If it's in the moderate category, then they need more than one to be placed on aspirin. And then we can go to the next list, or the next slide, excuse me. So I have created, because there's so many things to remember when we're seeing our patients, I have created in our EMR a kind of drop-down menu with those risk factors from the last table. So the top kind of part is my drop-down box, and I just have it that I use in my early OB visit or my new OB visit when I see my patients, and it's my reminder that I use. So I will just kind of I F2 through it, so I drop down through it, and the first box that opens is the first blue box. And those are my high risk kind of factors for my patients. And so I can just check which ones they have. Again, if they have one of those, then that means they should be on a baby aspirin. And then the second box you'll see will open, and those are those moderate risk factors. And so if they have more than one of those, then I know my patient should be on the baby aspirin. And so then at the top again, then I have another question to myself, and it says, yes or no, should the patient be on a baby aspirin? So I can document that in my note. And then within our EMR, I have actually an OB sticky note. So I can put a note to myself that reminds me that I need them to start on a baby aspirin during their pregnancy. So Colette and I were just talking about different ways to make it easy for us to remember all of these things, right, that we have to remember during pregnancy, but all of these risk factors to evaluate your patient. And this is what I've created in our EMR system. And go to the next slide. So preeclampsia, we believe, occurs because of an imbalance in prostacyclin and thromboxane A2 metabolism. Aspirin inhibits that thromboxane A2 at lower doses. So it works as an anti-inflammatory, anti-angiogenesis, and antiplatelet. They recommend an 81 milligram per day prophylaxis for women that are at high risk of preeclampsia. And it's best initiated between 12 to 28 weeks, ideally before 16 weeks. They do recommend, which I learned preparing this talk, that it's best if they take it at bedtime. So that was out of one of these recommendations. And when to stop it, there's 2 kind of thoughts on that. So one is that stopping it at 36 weeks because of the possibility for risks of bleeding at delivery. The other is that most preeclampsia occurs after 36 weeks. And so that aspirin may be beneficial to continue through delivery and into the postpartum period. So I think you probably just need to individualize that with your patient based on what you believe they're more at risk for. You can go to the next slide. So in 2017, the USPSTF found that low-dose aspirin in women that were at increased risk for preeclampsia reduced their risk for preeclampsia by 24%, for preterm birth by 14%, and by IUGR by 20%. So some pretty significant benefits for your patient. The low-dose aspirin should be avoided in patients that are have aspirin allergies or have had an adverse effect to this in the past. They have aspirin-sensitive asthma or GI bleeding. And there's been no risk associated with taking prenatal aspirin. So you can, I think, reassure your patient that this would be safe to take during pregnancy. Go to the next slide. And finally, the Preeclampsia Foundation has some good material. There is a handout that you can share with your patient to, again, reassure them about benefits of aspirin. There are some information also on that website available both in English and Spanish. And then they have a video that, again, you can utilize for patient education. So I'm happy to take any questions if anybody has any. Thank you.
Thank you so much, Dr. Briggs. If there are no questions, we'll move right into Dr. Lassard. She is going to continue this toolkit for us. Dr. Lassard is an OBGYN physician at All True Health Systems in Grand Forks. She attended medical school at the University of North Dakota and completed her residency at the Mayo Clinic, and she's also on our leadership team. So Dr. Lassard, I'll let you.
All right, and you're controlling the slides, right, Morgan? Okay, perfect. So I'm going to cover the second half of some of the highlights that Dr. Briggs and I thought would be important to bring to this learning session from the updated toolkit from CMQCC. So my presentation is going to review safe ways to coordinate care with your emergency departments and transfer of care from rural facilities. Reminder, we're going to go over a reminder about the appropriate timing for postpartum follow-up and debriefings with your team. So these toolkit updates, just as a reminder, they come from the Joint Commission's publication for standards for maternal safety that was published a little over 2 years ago. The whole purpose of this document is for helping facilities to reduce the likelihood of harm related to maternal severe hypertension and preeclampsia. That's why we're here today. CMQCC's toolkit updates the guidelines really on best practices for hypertensive disorders. Things change in medicine, things evolve all the time. It's just crazy to me how much I feel like has even changed in my 8.5 years of being out from residency. So this is a really great toolkit. The document's very detailed, but has really some nice up-to-date information for all of us. It's organized like the AIM bundles into the 4R principles: the readiness, recognition, response, and reporting. So for readiness, so educating our emergency department providers. So this really comes right from one of these Joint Commission documents for our birth centers. Point number 3 is providing role-specific education to all staff and providers who treat pregnant and postpartum patients about the hospital's evidence-based hypertensive disorders of pregnancy procedures. So sometimes I think we forget that it's more than just the family birth center units or labor and delivery units that treat postpartum and pregnant patients. And so incorporating a way to educate your emergency department staff is really key to early treatment and identification of many of these cases. So the emergency department is often where patients with symptoms or signs of severe hypertension present for care after delivery. And there's a section in this updated toolkit on helping your emergency department staff treat these patients rapidly and work with your OB team. Next slide. I won't go over this in detail. We've all seen this. This is the diagnostic criteria from ACOG for preeclampsia and preeclampsia with severe features. But the toolkit has really nice charts like this that you could put into a condensed document for your emergency department team. Maybe they want it laminated somewhere for an easy reference. So just so that you're providing them with this information. And again, you don't have to reinvent the wheel. You can scroll through these pages and really kind of screenshot some of them and put together a really nice reference sheet for your emergency department staff. And this box, I feel like just really states really well what we'd actually talked about in the last learning session about the diagnostic criteria for preeclampsia. So just a reminder that if your patient has been diagnosed with gestational hypertension or preeclampsia, and they meet blood pressure criteria for severe hypertension, they have immediately become a preeclamptic patient with severe features. So just making sure to educate all your staff, including the emergency department, on this. Do not wait to treat this hypertensive emergency. And I try just on the bottom of my slides occasionally to put the pages like down here of where this is referenced in the toolkit if any if anyone wants some of these documents or tables. So why is it important to educate our emergency department staff? Hypertensive disorders of pregnancy is one of the leading causes of maternal morbidity and mortality. There has been an overall decrease in the frequency of eclampsia. However, the frequency of postpartum and delayed eclampsia has increased. This makes it more common for these patients to present to our emergency departments. I don't know about you guys, but I'd be interested to hear at all true postpartum patients go to the emergency department. Is there any facilities where all of your postpartum patients are instructed to come to the birth center for any concerns? Unmute and speak up if not. If so, I think most of us, our patients go to the ER, right?
We had Brookings, if they present an ER and they're within that 6 weeks, we either need an OB consult or have them come up to us to make sure we're not missing any of those.
Nice.
Same in Fargo, they would present in the ER and then they would put in an OB consult if needed, if they were postpartum.
Yeah, so that's what they do here too, is they'll, present to the ER, but then they'll consult us. And I love our ER staff. I think they're wonderful. But while I was doing this presentation last week, I had a case that just really kind of hit the nail on the head for this. I had one of our ER attendings page me at 8 a.m. and he's like, I'm just wrapping up my shift and I feel like I might have missed something. One of your patients came in at 2 a.m. She's 5 days postpartum. She had gestational hypertension. She wasn't on meds and she was discharged 2 days ago. She was actually set up to see me the next day in my clinic for a blood pressure check. And he said she came in with this really bad headache, but her blood pressure was mild range and it went away when she laid down. And it just sounded like such a classic spinal headache that I sent her home and told her to follow up tomorrow, like scheduled. He's like, I'm just documenting and I'm worried that maybe I should have done more of an evaluation for preeclampsia or had you guys come and evaluate her. So I called her and had her come to our office, and sure enough, she had liver enzymes in the 90s, and she had those 155, 158, 159 systolic blood pressures, and she was readmitted for postpartum severe preeclampsia. But I was really thankful that he recognized it, even though it was 6 hours later, right? But this just reminded me of how important this is to create document and education for our ER providers so that they just always call us with these things. So obstetric consultation is warranted in every case of preeclampsia, and then just all clinicians working in the ED, so NPs, PAs, ER docs, family med docs, our nursing staff really need to be knowledgeable and comfortable with the initial management of hypertensive disorders of pregnancy. Just reminding them that most of these patients presenting to the ER will have no history of preeclampsia, and just educating our ER personnel on the varying presentations, diagnoses, and treatments for rapid identification and triaging of these patients. Next slide. So providing them, like I mentioned, information and resources so they can recognize these signs at the first first entrance to the ER. Really, one of the most important first steps is making sure the ER is identifying whether these patients are or have been pregnant in the last 6 weeks. I think most ERs are pretty good at that, but the postpartum piece maybe could be improved. So the triage should always make sure to ask, not just are they pregnant, but have they recently been pregnant? And then if yes, having your ER staff trained to, assess them immediately. Education on what critical blood pressure numbers are in pregnancy and postpartum. And I've had this conversation many times with our ER physicians that they're still trying to, remember that like what is a critical number to us is not to them. So it's a different training in the thought process. Like a blood pressure of 162 systolic in a patient in the ER isn't really alarming like it is for us with our obstetric and postpartum patients. So pregnant and recently postpartum women with elevated blood pressures, neurologic symptoms, and other signs of preeclampsia can deteriorate very rapidly. We need immediate communication between the ER and OB physicians. And it's also important, though, to remember not to overlook other neurological causes of seizures, because those can also happen, and not to withhold neuroimaging if it's clinically indicated, whether pregnant or postpartum. If a patient is presenting with seizures or neurological symptoms in the first trimester, early second trimester, or well into the postpartum period, beyond the 6 weeks, they really need a full evaluation for conditions other than preeclampsia, because this would be a very unusual presentation for preeclampsia. Neurologic deficits can also be associated with cerebral vasoconstriction syndrome, also known as PRES syndrome, posterior reversible encephalopathy syndrome. And then making sure to discuss like best practice and workflow for your individual facilities with how to triage these patients. Is it best to just call the OB floor and talk to the charge nurse? Is it best to page the attending? And just working together to make sure it's a smooth, streamlined process. Okay. And then just some statistics or reminders for why we care about this. Up to 26% of eclamptic seizures occur beyond 48 hours. And as late as 4 to 6 weeks after delivery. That's a really large number when you think about it. Most occur within the first 7 days of delivery. And as many as 3/4 of these patients, these postpartum patients, have no previous diagnosis of hypertensive disease with their recent pregnancy. And then I just asterisk this, 50% of women with gestational hypertension will develop preeclampsia. So this is like my recent patient who I just told you guys the example of who came to the ER and was readmitted postpartum. The most common clinical presentation of delayed postpartum preeclampsia may be really atypical, but also the most common symptom is the headache. And we know pregnant and postpartum patients can have a lot of headaches. So making sure not to just be too casual and pass off, oh, it's just another headache of pregnancy, because this is the most common symptom with preeclampsia. Next slide. So the focus for management with the ER personnel, maternal resuscitation, of course, blood pressure management with the first line agent. So making sure they're aware of what the first line agents are, and maybe having a little laminated tip sheet with the doses. Seizure prophylaxis, being mag sulfate, and making sure they're comfortable with the dose and how to get it started, especially if you're at a rural facility. I was just speaking with one of our rural facilities, and one of our labor and delivery nurses works there and flexes for us. And so she helped them get their whole kit. They have this kit just in case there's a delivery there, and they have mag, and they have the dose, and they have the hypertensive meds, like just for when those cases come in, so they can safely get this stuff going before they're transferred to us. If a cardiac arrest occurs in a pregnant or postpartum patient on mag, a reminder that along with your standard ACLS to give calcium, gluconate or chloride. And then just also to make sure your ER staff are aware of the risk for pulmonary edema and cardiomyopathy, and to have a really low threshold to evaluate for those things if they have any shortness of breath or low O2 sats. And again, just trying to treat with first line agents as quickly as we can within 30 to 60 minutes to reduce the risk of maternal stroke. And then this really is just kind of a summary of what I went over. So I won't read it word for word, but the last bullet point on here was probably the most striking to me. So among women who died from pregnancy related causes, 2/3 received care in an emergency department sometime in their prenatal or postpartum period, with nearly 40% having more than 2 visits to the emergency department. So again, they are also some of the first line staff that see our patients. So this is an example in that bundle of a really simple sign that can be placed at your ER check-in. Doesn't have to be this, but something like that, just a reminder for the patients even to advocate for themselves. Are you pregnant or have you been pregnant? If any of these signs, just come up to the front of the line and say, I have to be seen now. And then setting up safe transfer of care. So all of these points, like I mentioned, are pertinent for all of those rural facilities that we accept transfers from. So reaching out and offering just to provide some reference sheets, maybe just a 15-minute like lunch Zoom update on some of this stuff, developing a workflow or a system to ensure that they feel they can call with any questions about this and help ensure rapid and safe transfer, and making sure that they feel comfortable initiating these first line agents and creating a plan with their staff for them being able to do so. And this is just another example of one of the tables in this document that you could use and give this to your rural facilities, your ER. They are probably not, and unless they have family med OB docs like in Devil's Lake, for example, like Dr. Foudy was mentioning, how their ER always calls that family med OB on call when they're immediately postpartum, which is great. But unless they have like OB trained providers, they may not be aware of any of these documents to pull for themselves or to know to reference. We have just a couple more slides here. So one slide on postpartum follow-up timing, because I feel like we have talked about this in a couple learning sessions before, but just a reminder that anyone with severe preeclampsia needs to be followed up ideally within 2 to 5 days of discharge. And if any patients are sent out on any antihypertensive medications during their hospitalization, they should have a follow-up appointment within 3 to 7 days of discharge. And then all other patients diagnosed with hypertension but not treated with meds should be seen within 1 to 2 weeks of discharge. And then just a few more minutes on debriefing. So this is a really important piece of optimizing maternal care. I liked this quote in the toolkit: to provide the best possible outcomes for women and newborns, it is imperative for facilities that provide maternity care to establish a systems learning culture dedicated to perinatal quality, safety, and performance improvement. So we always have to be looking for how we can do better. Debriefs and multidisciplinary reviews are just really key components of standards by JCAHO and ACOG. They provide foundational learning about how we can improve. They just make your team, your clinical team, really highly reliable and promotes a culture of safety, which is important for being able to speak up if you think something is not right. And ideally, debriefs should happen after the event when possible. It just allows the team to really focus, take a few minutes, and problem solve in real time. And it should just be made a part of the daily routine activities on the unit. And this is challenging to do. I totally acknowledge this, and I personally need to be better about this, I would say. Next slide. The goal with the debriefing is to formally and quickly assess the overall care the team provided, review to see if there's any potential gaps and deficits, and to improve care for the next patient. This should be safe and non-punitive, so no one's at fault for not pointing fingers. And the goal is to implement system learnings from these debriefs and reviews. And you just need to do it. You just need to, especially some of the providers and lead charge nurses here, you just need to, in your next sort of maybe difficult delivery or patient with hypertension, just go to the nurses station and say, hey, let's have a debrief. This is really the best practice, but it's difficult for units to embrace, as we know we're all short-staffed and strained and busy. Limit them to 5 to 10 minutes. If it were to need any more time than that, it really should be something that's brought to a multidisciplinary case review, especially for really complicated cases. This is the component. So what went well, you can just start by asking your team. We just had this difficult shoulder dystocia. What went well? What could have gone better? And then what needs to be followed up on later and by whom? So I just made up an example this morning. And so this is just my example, something really simple, but something that there's room for quality improvement. So in a routine scheduled cesarean, the obstetrician is having difficulty delivering the head through the hysterotomy and requests the Kiwi vacuum. Nursing staff open the cabinet to retrieve a vacuum and there are none. The nurse quickly calls out the nurse's station and another colleague is able to grab one from a labor room and bring it into the OR. The baby is born 90 seconds after the vacuum was requested with APGARs of 5 and 9. So no bad outcomes, but potentially, if heart tones could have been down and that could have been an emergency. a delay of 60 seconds can make a difference. So you could just go to your team afterwards and say, you know, what went well. And so it sounds like the nurse in my hypothetical example was able to really quickly call out and reach another nurse in the nurse's station. What could have gone better? So how can we ensure that our OR is always stocked with necessary equipment and we don't miss restocking with things? If the physician's anticipating a difficult delivery, she or he could have asked ahead of time, you know, while the patient is being brought into the OR, can we make sure there's a vacuum available? Or, you know, can I have a second? I might need extra hand. And then what needs to be followed up on and later and by whom? So discussing with surgical techs and nursing staff about having a process in this family birth center unit to make sure that supplies like this that you don't use with every case are always restocked. Another example is like debriefing after a shoulder dystocia, you know, were you able to get help quick? Was the NICU easily available, etc. Okay, I have like one or two more slides. So multidisciplinary reviews of severe maternal morbidity events. JCO requires birth centers to review cases of hypertensive disorders of pregnancy and their processes for improvement. It's also recommended that you expand the types of cases that you review to include those that involved severe maternal morbidity events. So a patient who needed a massive transfusion, 4 units of blood or more, if a pregnant or postpartum patient was admitted to the ICU, eclampsia and severe HELLP syndrome or stroke patients should be considered in this. And then just those cases requiring multiple intensive resources or with a really challenging clinical scenario. And you could consider at your facility establishing a local perinatal patient safety program to make sure that this consistently happens and just ensure that that quality improvement process is happening. Next slide. That's it. So this is just a link to the toolkit for anyone looking for any of those tables and resources. Any questions?
Thank you so much, Dr. Lessard. I know we are running a little low on time, but this next presentation I think is very important. Stephanie Ducato is one of our partners at Tribal Nations Research Group. And she is an enrolled member of the Turtle Mountain Band of Chippewa Indians and a mother of 2 sons. She holds a BA in psychology and an MSW from the University of North Dakota. I'm just gonna shorten her bio real quick, but she has been at the Turtle Mountain Community College as the director of Native American Training Institute in Bismarck. And she is a member of the TNRG group in Belcourt. In her free time, she likes to create beadwork, spend time with family, friends, and travel. Stephanie, I will let you go from here. We might not have time. We're probably not gonna have time for storyboards afterwards, but we will share those slides with everybody. So Stephanie, did you want to share your slides?
Yeah, I'll share my screen. Thank you.
Okay.
Let's see. And of course, let me try this again. Okay. Good morning, everyone. There's a few minutes left in the morning. My name is Stephanie Ducato, like Morgan said, and I work with Tribal Nations Research Group. And Tribal Nations Research Group is a partner in this NSDPQC program in the grant, and working with the tribal communities in North Dakota and South Dakota, and trying to get them involved and make sure that information is shared in an appropriate way within those communities. So I will be giving you a short presentation today, and this is going to be just like a total left turn from what we've been listening to all morning. And I tell you what, I know now how to position myself when I'm at the doctor getting my blood pressure done. So this has really been good for me. But I do want to say that Molly Lilly is part of our team as well. She's a community outreach person, and I have to credit her. She did like a lot of this research for me. I've given a lot of presentations on working with Native Americans in various settings, but Molly found the goods on the resources for this one. So So just a quick overview. I don't want to spend too much time on this, but it's really important actually to understand kind of just that history of Indigenous people in the United States and that relationship that we've had, and because it plays on our situation today. This surprises me. This is from the 2000 census, that about 3/4 of Native Americans live near urban areas, not reservations or within their tribal community. That's about 3 million. That's, to me, that I just, every time I hear that, I think, no, because we're all here, we're all home in our communities. And I live within my tribal community up in Turtle Mountain. So that's a big portion of our people out away from their communities and accessing healthcare in different ways than we are here back home. And so that means we have a lot of, like I said, a lot of our tribal members don't have access to our treaty granted healthcare benefits, usually IHS, you'll hear it called, Indian Health Service. And I just wanted to put out there that when I'm away from my community and I'm not living in the Turtle Mountains in Belcourt or Dunseith, I don't have access to those services the way I would if I did live here. So I can't go to a facility. Most tribal most tribes, you can't just walk into a facility outside of the IHS, use your card and say, I don't have to pay for this service because that's what we do at IHS, right? So there's a lot of strain in that, in knowing that you can't just walk into your healthcare provider. It's a luxury we have. There's a lot of reasons why we have that luxury. But so it causes an extra strain when somebody's away from their community. And in some cases, IHS will pay for some things, but it has to be pre-approved. So if I go out of town and I have my kids with me, and when they're at a basketball game and one gets injured, I can't just go to the emergency room and know that IHS is going to cover that for me. That has to be pre-approved. So it causes a little bit of stress, and it's a different situation in our healthcare for us, for our communities. So the other thing to think about when working with Native American patients is there's a history of mistrust in mainstream institutions, organizations, the federal government. We have this pendulum of policies that I call it, and some of those policies that came down from the United States directly specific for tribes were empowering, provided opportunities for self-determination, self-governance, but some of them were really the polar opposite, where we had broken treaties, we were forced into boarding schools, forced relocations, forced sterilization is one, and policies that ban traditional practices. Forced sterilization was in the 1960s. And I bet a lot of people in this room were living in the 1960s. That's not very long ago. And so unknown for sterilization as well. A woman would go in, have a baby, and be sterilized in the same procedure without being informed. So there's a lot of mistrust, and that's something that we'll kind of talk about later on, and how that plays out in the room when you're taking their blood pressure, right? It's just, it seems like such a big jump, but it affects it. So acknowledging that history, knowing that history, and not every tribe is the same, and we don't all have all the same history, the same story, but we have some similarities, and knowing that is an important step to building a relationship and a trust relationship with your patient. And then also knowing that every individual that comes in your door that is Native American or identifies as doesn't have the same the same level of involvement or acculturation into mainstream society versus their own. So I tried to make that fast. That was really long. And we do the cardinal sin of putting a lot of words on our slides. So the next thing, was I on the wrong slide the whole time? I hope not. Oh no, okay. The next thing is our history with medicine. And, we have our own history and relationship with healthcare and medicine. Healing traditions vary by tribe. Medicinal things that we use for medicinal use vary by tribe. We have ceremonies that vary by tribe, but we all have this consensus that there's a balance. Health requires a balance, spiritually, emotionally, physically, mentally. And when one of those things are off balance, it creates an issue for all the other pieces, and it creates strain, right? And so the other thing is that we know these things, we know these medicines, we've used these medicines for thousands of years, we've done our own research, right? And we know what works and we know what doesn't work for us. And so it's kind of been, and now we're starting to, so mainstream America is coming to terms with like, okay, yes, this knowledge is valuable. Whereas when there was first contact, it was deemed not valuable. Give up your traditions, give up your language, give up your medicines, your practices, your ceremonies, illegal. They were literally illegal. So as a nation, we're actually coming to terms with, okay, there's some value in that. There's some value in using and in using holistic medicine, and that it is effective, and it's actually been used for the whole time. I mean, some of the medications that many of the herbs that we've used have been used in prescription drugs, been made from plant extracts over time. So we know these things are true, but acknowledging it is sometimes the difficult part, right? So there's this Salish, the first female Native American author from the Salish tribe. Her name was Mourning Dove, and I need to move this little picture because it's in my way. Wrote, everything on earth has a purpose, every disease an herb to cure it, and every person a mission. This is the Indian theory of existence. And so that's where that holistic view comes from too, is that, you know, we're here, everything that we've needed was provided for us in our environment. And this kind of goes back to thought throughout many modern US medical schools, and even originates centuries ago and is connected to the Hippocratic Oath in some way. So all the information I have are on these links at the bottom if you want to look more into them. And so whether modern field of medicine has over time has recognized it or not, Native Americans are intricately intertwined into the history of medicine and have contributed greatly to it. We're kind of coming full circle. That's what it's a saying, but it's true. It's happening right now before our very eyes. And so another resource that we really wanted to showcase and share with you is a presentation out of Minnesota that mostly was concerning psychology care with patients and clients, but these 3 C's really can apply to the medical field as well. So the first C is context, and that's understanding the story. And, you know, nobody's ever going to be proficient in all tribes. That's like seriously impossible. We only have 5 tribes in North Dakota, and that's even impossible to be proficient in all that knowledge, right? It's overwhelming. But the key is to understanding that there is a general relation, there's a general history that we share as tribes in our relationship with the US government, healthcare, education, all those fields. We do have a shared history that we acknowledge and we understand, and we walk this world knowing that history as Native people, because we're taught that, right? The other thing, again, was understanding that there are many levels of acculturation among Native people. So understanding that not every person is going to talk to you about their traditional medicines that they may use, or their herbs that they use, or ceremonies that they participate in. And even if they actually talk about that, but some people really are into that, and some people have not had that connection. The next C is comfort and building it. And I was so proud when I thought of this little statement, people before paperwork. I mean, it may not be new to anybody else, but to me, I was like, yeah, I should have like quoted it and highlighted it, but people before paperwork. And that's really important with your Native American clients, getting to know them. I'm sure it's important with all human beings, right? Some people are accustomed to just like getting in there, doing their paperwork and moving on. But if you have a person in a situation with that kind of history that we've talked about, that understanding, that mistrust, maybe for healthcare field, healthcare professionals, the insecurity they may have that I don't know, I don't know as much as this expert does. Getting to know your client, even before you put a piece of paper in front of them to fill out. Even if it's just a short conversation, just making a connection. I know that we don't share too much with clients and patients, but giving a little bit of information about yourself, will help them open up about themselves. When I did my dry run through this yesterday, I kind of just did a quick thing like, oh, asking about how the weekend was. How was your weekend? Oh, start talking. Well, I went skiing and I'm really sore this week today. I'm really feeling it today. Just something little, just a little bit about who you are as a human, and that you're willing to interact and engage with that individual, and doing that with sincerity, and is really what's the word? I'm going to lose the word. Effective. Showing interest in who they are as a person. Maybe you say, oh, you're from Spirit Lake tribe. I grew up in Devil's Lake, or I have cousins that live near there, and I travel that way all the time. It's a beautiful country, whatever. Something small, but something that's significant to them. Connection is really important in Indian communities. You'll see I say Native American, Indian, back and forth, Indigenous. It just depends on what my sentence is, but connection is very important. And one thing I want to, an example I want to give to that is when I introduce myself to somebody in my community. Let me grab a drink of water here. When I introduce myself to somebody in my community, I will say, oh, I'm Stephanie Dakota. My parents are Steve and Geraldine Dakota. My grandpa's Fritz, or my grandma's Caroline. Because in our communities, that's how we connect to each other. And I think in small town, in rural, communities, they do that too, right? Because they'll say, it depends on or I might say my niece. If I'm introducing myself to a younger person, my niece is Simone, or Annie. But it's making connections like that. And it's really important to feel that familiarity with that person. Communication is the last of the 3 C's. And these are probably things they seem like common sense, but just a reminder, that building rapport and alliance with that individual, with your client, your patient, you're not here to just take info and leave. That can be very, especially with our history in engaging with organizations and US government, giving our information and never getting anything back is a big issue. So not understanding why we're giving you this information, or not understanding what this information is going to tell you about me as an individual in my healthcare. So, but to learn together about the patient and what can be done to help improve their health. That's the important part. And showing a genuine interest and sincerity, like I said earlier. I'm almost done. I know I'm trying to go fast because I know this goes till 12, right? I think I'm on my last. And here's the good stuff. I want to say before we finish that, I would love if you had burning questions that we don't talk about today or cover, that you've had scenarios that you've encountered in your work. Put them in the chat box, because I got Molly on the line. She's going to write them all down, and I'll come back and maybe do another 10 or 15 minute presentation next time. I want to make sure that we're answering, your burning questions, and we're addressing issues that you faced, and how to maneuver through that. So tips when engaging with Native American patients. Eye contact is always like the first thing that people talk about, but it is a real issue, right? And in some of our communities and some of our tribes, eye contact is kind of a challenge. So, I don't look at my mom right in the eyes for very long when I'm being disciplined, because I'm challenging her in a way. And it might also, there's other reasons why people will not make eye contact. It doesn't mean they're not listening. It doesn't mean they are not understanding. It doesn't mean they're not engaging with you, because they're using their ears. When you're not looking at something, you're still paying attention with your ears, right? So that's one thing about contact. Another big thing is not rushing for answers from the patient, because if you have ever had an experience with anybody from a Native community, sometimes silence is golden, and people will take their time to answer questions. They're trying to figure out, okay, what am I feeling? They're asking me about my health and how I've been the last 2 weeks. What is relevant isn't, and how do I say this to them? So don't rush them for answers, because it's going to shut them down right away. If they don't get to answer the question that you've asked and you've moved on, they're already closed. That's just kind of the bummer of it. Don't assume patient understands. Even if they're not asking questions, that doesn't mean they do understand. It may mean that there were so many things, there were so many acronyms that were used in the last 10 minutes while they were sitting in that room with you. There were so many pieces that they missed, that they want to understand, but they don't know how to ask the question. So don't assume that silence means they understand. That fear and mistrust that I talked about, with organizations within healthcare, as Native people, sometimes we don't even know that that's what we're feeling when we're in the doctor's room. We just know we have an uneasiness. We're not really sure why, but it's kind of it can come from a lot of different places. And part of that could be that historical trauma that we've experienced as a group of people. Being aware of personal space. I'm sure these are things that you learn about in your training, right? And in schooling, and how to work with a patient. Some of these are pretty common, but take the time to explain and share information. I must have had a really good first time doctor as an adult, because she always told me, or maybe it was the nurse checking me in, always told me my blood pressure. And ever since then, I'm like, so blood pressure, is funny that I'm in this project, because I know my blood pressure all the time, and I know what it's been. I know where I fluctuate, and I know if it's up to a certain level, there's something going on with me. But there's a lot of times now, and so I'm confident in that, right? But there's a lot of times when I get checked in at the hospital, and they do that check-in, weigh you, do your blood pressure, all that stuff. They don't tell me my numbers, and it irks me. It irks me to no end, because when I was first started in healthcare, in my own healthcare as an adult, I was told my blood pressure all the time by this one individual. And so it taught me how to advocate for myself and how to know what's important. That taught me that my blood pressure is important. And so when they don't tell me, I ask. And then I think about all the women who've never thought that they could ask what their blood pressure is. It's so important for them to know, and them to know. And they all would tell me too, oh, okay, mine's usually like 125/70. That's my blood pressure. You're in the normal range, and they just kind of talk and I've learned this over time, what normal range is, not from reading a book, not from reading an article, because my healthcare provider told me. So that's really, really important. And acknowledging and incorporating traditional medicines into the treatment plan as well. Acknowledging that they may take certain herbs, they may participate in certain ceremonies, and acknowledging that's a real thing, and that is really helps them in their balance, keeping their own balance and keeping their healthcare in check, and using that and incorporating that into their plan, and understanding that they're going to do that, right? So the quote at the bottom, there's a lot of people that this is attributed to, this quote, or some variation of it, but tell me and I'll forget, show me and I may not remember, involve me and I'll understand. And that's why I know my blood pressure, and I know what it ranges, and I know when I should be worried or not, because I've been involved from day one. So that's really important. I think you're the teachers when we're in that situation as a patient. You're the teacher in that moment, right? So I tried to rush through really fast, because I know that this has been a long morning, and I have other stuff to do too this afternoon, but are there any questions? And if you don't want to ask in here, type it in, like I said, and we'll get Molly we'll address it next time too.
And if there's any questions, if they want to email me, I can send them on to you as well.
Yep.
That works too. Thank you, Stephanie. Next time you get top slot in the agenda. I don't know how we got so far off of where my plan was for everything, but it was
That's
great
okay.
discussion, and I'm so glad we got through all that we did. I apologize about the storyboards, all the work that you guys put into those, but I will share those with the group along with all of the slides from today's meeting. So if you want to go back, look through the slides, we'll also have the recording to share. So thank you all for being here. Have a wonderful afternoon. And is there anything else from anybody that they want to hit on?
Thanks, Morgan.
Thank you. Have a good afternoon, everyone.
Yeah, thanks everybody.
Yeah.